My people, no allow sore throat and cough kill your voice and dabaru your day. Finish them with Shalto lozenges wey dey gidigba to kpafuka cough and sore throat with better fresh breaths. Shalto lozenges contain 5 natural active ingredients like ginger, turmeric, valeric, licorice, and mint. Think natural. Think Shalto, natural sore throat reliever. If symptoms no gree go after 3 days, consult your doctor.
Shalto lozenges.
Charlie, committing to work in Accra on a daily basis is no mean feat. I get to spend a bulk of time in traffic on a weekday and still get to join my dance team for our regular daily dance rehearsals. Yes, dance is an aspect I love to keep alive. I need to be at the 100% all the time. So whenever the back pain hits as a result of sitting for too long or busting various dance moves, Ibucap is always with me and my go-to back pain body combatant. My name is Akonjo, and this is my Ibucap story.
Having to wake up as early as 5.
Them. 1, 2, 3. Amen. Please be seated. All right, without further ado, I would like to acknowledge the presence of some of the management staff of Shalina Healthcare. Of course, Rising Star Season 3 is powered by Shalina Healthcare. And right here we have some of our senior management team, and I would just like to acknowledge their presence at this time. So first and foremost is the Managing Director, Shalina Healthcare Nigeria OU, the person of Mrs. Okpeyemi. Welcome, Ma. Also, we have the Head of Brand Marketing, who happens to be a key coordinator of this event, the person of Pharmacist Folorunsho Alaron. Okay, co-emceeing with me today is the Head of Training, Shalina Healthcare. Is it West Africa or Africa even? You have gone to Magadugu, you've gone to Global. Head of Training, Farm Ayo Akishola. All right, we have other members of the team. I know I saw the Head of Brand Marketing, Sandeep Sahu, around earlier on. And we have the Head of Demand Generation for Institution and Cardiovascular Business also. They are around somewhere. I can't see them in the hall right now, but they are with us. They will be seated in a moment. So having done that, I would like to move on to Farm Ayo to do the honors of inviting up our contestants for today as well as the panelists for the occasion.
All right, standing on existing protocols, I want to warmly thank everyone and welcome you to this auspicious occasion. We appreciate your presence, and as much as possible, even though we are starting late, I want to assure you that we'll move with the speed of lightning and get done in a jiffy. So, first and foremost, we'll call on the contestants, those who have made today's presence more concerning. Right. Chuba, please. For the contestants, so we'll be calling on the contestants one after the other, and they already have their seat numbers. Please, when you are called and your citation is being read, you will do well to kindly walk to your seat number, please. It's been labeled from 1 from my left hand to 15 on my right hand. Thank you. First one. Okay. All right. We are meeting the contestants. Number 1 is Dr. Lere Peter Oluwadare, graduated from University of Ilorin, Kwara State with a Bachelor of Medicine and Bachelor of Surgery degree in 2011. He's a senior registrar in the Department of Pediatrics, University College Hospital, Ibadan. He's a member of the West African College of Physicians and Faculty of Pediatrics. Senior residency program was done in general pediatrics at the University of Ibadan, UCH Ibadan. He has participated at numerous academic conferences locally and internationally, and presently a member of the International Parkinson and Movement Disorder Society. Just concluded his fellowship training, Faculty of Pediatrics in West African College of Physicians. Professional membership includes, but not limited, to the Medical and Dental Council of Nigeria, West African College of Physicians, International Parkinson and Movement Disorder Society. Please join me as we welcome Dr. Lere Oluwadare from UCH. You're welcome, Doc. Next is Dr. Oduola Owo Babatunde Badmus, graduated from University of Ilorin with a Bachelor of Medicine and Bachelor of Degree in 2010. He's a consultant in obstetrics and gynecology unit of Federal Medical Center, Ebute Metta, Lagos. He bagged his fellowship of West African College of Obstetricians and Gynecologists in 2020, and fellowship was also bagged in 2023. He has been privileged to have his obstetrics and gynecology trainings at both local and international settings, and residency training, during his residency 20 years. He had his senior residency training in O&G at Federal Medical Center, Ebute Metta, and Lagos State University Teaching Hospital. He currently works with the Federal Medical Center, Ebute Metta, Lagos. He's a member of the Medical and Dental Council of Nigeria and West African College of Obstetricians and Gynecologists. Please join me as we welcome Dr. Badmus Babatunde. Next is Dr. Anekan L. Jackson, graduated from the University of Calabar with a Bachelor of Medicine and Surgery, and also bagged the fellowship of National Postgraduate Medical College of Nigeria in November 2023, a post-part 2 fellow in the Department of Obstetrics and Gynecology, University of Uyo Teaching Hospital, Akwa Ibom State. He had the privilege to co-author a research on prevalence of rhesus negative status amongst antenatal attendees in the University of Uyo Teaching Hospital, Nigeria, a 5-year review, which is available online on ResearchGate. His training was solely in the University of Uyo Teaching Hospital, which comprised of the junior and senior postings, involving rotating through other departments like general surgery, urology, histopathology, anesthesia, neonatology, and community rural posting. He is currently a fellow of the Medical College of Obstetrics and Gynecology, working at the University of Uyo Teaching Hospital in the Department of O&G. He's a member of Medical and Dental Council of Nigeria and also National Postgraduate Medical College of Nigeria. Please join me as we welcome Dr. Anekan Jackson. Thank you. Next is Dr. Sokepirim E. Ikiroma, graduated from University of Port Harcourt in 2008. He's an enthusiastic clinical healthcare provider. After a successful completion of his housemanship, he proceeded to partake in the NYC program and was posted to the Comprehensive Health Center in Ilawe, Ekiti. He then worked as a medical officer and later underwent medical residency training in obstetrics and gynecology at the Rivers State University Teaching Hospital in Port Harcourt. He was the chief resident in the Department of O&G, Rivers State University Teaching Hospital, Port Harcourt, from 2021 to 2022. Following successful completion of his medical residency program, he was awarded the fellowship of the West African College of Surgeons in 2023. Currently, he is a consultant O&G with the Rivers State University Teaching Hospital, Port Harcourt, and a lecturer in the Department of Obstetrics and Gynecology, Rivers State University, Port Harcourt. He's a member of the Medical and Dental Council of Nigeria and West African College of Surgeons. Again, please join me to welcome Dr. Sokepirim Ikiroma. Thank you. Next is Dr. Maduka Collins Gideofo. He graduated from Nnamdi Azikiwe University with a Bachelor of Medicine and Surgery degree in 2009. A senior registrar in the Department of Hematology and Blood Transfusion of University of Nigeria Teaching Hospital, Ituku Ozala in Enugu State. Practiced as a medical officer for a couple of years before enrolling into residency in 2015. Passed his Part 1 examination with National Postgraduate Medical College of Nigeria in 2018. Has also backed and be engaged in personal capacity training, leadership, research, and social services. In 2019, he became the secretary of a non-governmental organization, TAC McG Initiative, tasked with rendering health talks and voluntary viral screening to individuals in rural areas. He obtained his certificate in leadership and management in health from the University of Washington in 2021. In 2022, he co-authored a book in hematology termed How I Manage Cancer in a Developing Country, the Case of Multiple Myeloma. He was the chief resident doctor of his department from January 21 to 2022, November 2022. In 2023, he was nominated to partake in proficiency training in the field of molecular medicine in the training institution. He also has scholarly publications in hematology and other related disciplines. He is currently a member of the Medical and Dental Council of Nigeria. Jam your hands as I welcome Dr. Maduka Collins, GD04. Next is Dr. Ozazi Ude Eguage. He graduated from the University of Benin with a Bachelor of Medicine and Surgery in 2008. He is a consultant in plastic surgery unit of the University of Abuja Teaching Hospital, Gwagwalada, Abuja. He bagged the fellowship plastic surgery of the West African College of Surgeons in 2023. He has had his senior residency training in plastic surgery at the University of Abuja Teaching Hospital, Gwagwalada, between 2019 and 2023. Currently, he works with the same hospital. He's a member of the Medical and Dental Council of Nigeria and member West African College of Surgeons. Please join me to welcome Dr. Ozazi Eguage. Next is Dr. Amefuna Kenechukwu David. Graduated from the University of Port Harcourt in 2010. He bagged his membership of West African College of Surgeons and that of Royal College of Surgeons, Edinburgh, in April 2018 and February 2023, respectively. He had his senior residency training in general surgery at National Hospital Abuja and Federal Medical Center Asaba between 2018 and 2023. While in residency program, he attended many conferences and trainings, among which a first Abuja Trauma Conference 2016 and all Safe Packs WACL's basic laparoscopy in 2023. He also served as the General Secretary of the Association of Resident Doctors in FMC Asaba and the Chief Resident in the Department of Surgery, FMC Asaba. He is currently with the FMC Federal Medical Center Asaba. He is a member of the Medical and Dental Council of Nigeria, West African College of Surgeons, and Royal College of Surgeons, Edinburgh. Please join me as we welcome Dr. Amefuna Kenechukwu. Next. Dr. Josephine Onumaku graduated from the University of Port Harcourt with a Bachelor of Medicine and Surgery degree in 2010. She is from the Department of Pediatrics, University of Port Harcourt Teaching Hospital. After her MBBS, she thereafter carried out her internship in the University of Port Harcourt Teaching Hospital. Following this, she served in the Medical Center Yenogua as a Youth Corps member. While awaiting the commencement of residency training, she was opportuned to serve as the team doctor for the then Dolphins Football Club of Port Harcourt between 2012 and 2013. After which she also served as a medical officer in the private sector, garnering hands-on experience in fields other than her long-desired practice of child health. She began her residency training in the University of Port Harcourt Teaching Hospital in 2016 and bagged the membership of the West African College of Physicians in Pediatrics in 2019. Today, she is a member of the Medical and Dental Council of Nigeria and West African College of Physicians. Please join me to welcome Dr. Josephine Onumaku. Next is Dr. Nwafo Ifeanyi Echenuzona. Graduated from Nnamdi Azikiwe University, Awka, with a Bachelor of Medicine degree in 2013. A senior registrar in otorhinolaryngology. Otorhinolaryngology, Department of Nnamdi Azikiwe Teaching Hospital, Nnewi, Anambra State. He bagged his membership of the West African College of Surgeons in April 2021. During his residency training, he had the privilege of taking the following courses: basic surgical skill, functional endoscopic sinus surgery, head and neck dissection, and temporal bone dissection courses. He also received training in research data analysis using STATA at Nigerian Institute for Medical Research, Lagos in 2021, and in minimal access surgery at the Always Live Institute for Endoscopy in collaboration with the Association of Endoscopy Surgeons at Oka, Anambra State in 2023. Currently is with the Nnamdi Azikiwe University Teaching Hospital, Nnewi. Is a member of the Medical and Dental Council of Nigeria and West African College of Surgeons. Please join me and welcome Dr. Ezechona. Next is Dr. Lawani Ufadime, who graduated from University of Benin with a Bachelor of Dental Surgery in 2008. Is a recently qualified medical dentist of the National Postgraduate Medical College of Nigeria from University of Benin Teaching Hospital. She had a housemanship between 2009 and 2010 at the University College Hospital Ibadan and National Youth Service Corps between 2010 and 2011 in Ilorin, Kwara State. She worked as a dental officer in Lagos from 2012 to 2017, after which she proceeded to University of Benin Teaching Hospital for a residency training program, where she bagged a fellowship in family dentistry from the National Postgraduate Medical College of Nigeria in November 2023. She obtained a master's in health planning and management from the University of Benin in 2023 November. She has attended several revision courses organized by the National Postgraduate Medical College of Nigeria and scientific conferences within Nigeria. She has carried out a couple of research studies, 7 of which have been published in both national and international journals. They include knowledge of local anesthetic anaphylaxis among dental practitioners in a Nigerian tertiary institution, a survey on awareness, knowledge, and attitude towards knees, oral cancer, referral guidelines amongst general dental practitioners in Edo State, a study on awareness, knowledge, and practice of radiation exposure protection protocols by dentists in Nigerian Teaching Hospital, prevalence and pattern of non-odontogenic tumors of the jaws in a Nigerian tertiary institution. She is currently with the University of Benin Teaching Hospital. She's a member of Medical and Dental Council of Nigeria and member National Postgraduate College of Nigeria. Please join me as we welcome Dr. Ufadime Lawani. Thank you. Right. Next is Dr. Taye Suleiman Kelani, graduated from University of Ilorin, Kwara State with a Bachelor of Medicine and Surgery. He trained as a clinical microbiologist at the Aminu Kano Teaching Hospital, Kano. He became a fellow of the West African College of Physicians in 2023. He is currently employed as a consultant pathologist at the Department of Microbiology, Federal Teaching Hospital, Katsina. His main areas of interest are antimicrobial resistance, population health, and human microbiome research. He is a member of Medical and Dental Council of Nigeria and West African College of Physicians. Please join me as we welcome Dr. Taye Suleiman Kelani. Next is Dr. Omolara Odunsi, graduated from the University of Lagos with a Bachelor of Dental Surgery degree in 2004, a senior registrar in Orthodontics Unit, Department of Child Dental Health at the Lagos State University Teaching Hospital, Ikeja. She also obtained a Master's of Public Health from the University of Lagos in 2012. She bagged the membership of West African College of Surgeons in April 2019. She had a senior residency training in orthodontics at Lagos State University Teaching Hospital, Lasut, Ikeja, between 2019 and 2024, during which she developed keen interest in clinical research with rewards, best poster presentations at the 14th and 16th Annual Scientific Conference of the Nigerian Association of Orthodontics in Lagos 2020 and Abuja in 2022, respectively. She is currently with the Lagos State University Teaching Hospital, Lasut, Ikeja. She is a member of the Medical and Dental Council of Nigeria and West African College of Surgeons. Again, she backed the best poster presentation at the 14th and 16th Annual Scientific Conference of the Nigerian Association of Orthodontists in Lagos. Please join me to welcome Dr. Omolara Odunsi. Next is Dr. Samuel O. Akwan, who graduated from the University of Calabar with a Bachelor of Medicine and Surgery in 2007. Is a consultant general surgeon with the University of Calabar Teaching Hospital, Cross River State. He had his junior residency training in surgery at the University of Calabar Teaching Hospital and became a member of West African College of Surgeons in 2018. He did his senior residency in general surgery at the University of Calabar Teaching Hospital and Obafemi Awolowo University Teaching Hospital Complex, Ife. and became a fellow of the West African College of Surgeons in 2023. In the course of his training, he had both open and minimal access surgery exposures. Currently, he is a consultant in the Department of Surgery at the University of Calabar Teaching Hospital, Calabar, Cross River State. He is a member of the Medical and Dental Council of Nigeria and West African College of Surgeons. Please jam your hands as we welcome Dr. Samuel O. Akman. Next is Dr. Uswanlele Aikomian, who graduated from the University of Benin City with a Bachelor of Medicine and Surgery in 2011, a young orthopedic and trauma surgeon with the National Orthopedic Hospital, Igbobi, Lagos. His residency training was at National Orthopedic Hospital, Lagos, between 2015 and 2022, during which he did his part of his junior residency posting at the Wafemi University Teaching Hospital Complex between 2016 and 2018. During his residency, he had the privilege of attending some trainings, such as the Institute for Global Orthopedics and Traumatology, training on open fracture treatment, termed SMART course in Tanzania, and Makadia Orthopedic Hospital in India in 2019. He obtained his fellowship degree in 2022 from both the West African College of Surgeons and National Postgraduate Medical College of Nigeria. After his residency, he did his post-fellowship training in arthroplasty and arthroscopy sports orthopedics at the King Faisal Hospital in Kigali, Rwanda, and Turan Orthopedic Hospital in Bursa in Turkey. Currently works with the National Orthopedic Hospital, Igbobi, Lagos. Is a member of the Medical and Dental Council of Nigeria, West African College of Surgeons, and one of the greatest achievements was I graduated as a best student during his West African College of Surgeons, Faculty of Orthopedics in 2022. Please join me as we welcome Dr. Uswanlele Aikomen. Last but not the least is Dr. Mariam I. Abdullahi, graduated from the Ahmadu Bello University's area with a Bachelor of Medicine and degree in 2009. Following youth service, she worked as a medical officer in both state and tertiary hospitals, Murtala Muhammad Specialty Hospital in Kano and AKTH respectively. She also obtained a Master of Science in Public Health, MSc Public Health from Bayero University, Kano, before commencing her residency training in ophthalmology at AKTH Kano. She also attended several conferences locally and internationally, including the Ophthalmological Society of Nigeria Annual General Conference meeting at Kaduna and another in Honolulu, Hawaii, USA in 2012. She completed her residency training in ophthalmology in November 2023 with the award of FMC Opt. Right. During the course of her residency training, she served as the chief resident of the department and currently a member of the Public Eye Health Unit and media focal person of the department. She is also currently a member of the Executive Council of the OSN, that's the Ophthalmological Society of Nigeria, Kano chapter. She works currently as a consultant ophthalmologist at the Department of Ophthalmology, AKTH, with special interest in glaucoma and public eye health. She's a member of the Medical and Dental Council of Nigeria and also an Executive Council of the Ophthalmological Society of Nigeria, Kano branch. Again, one of our awards is through the FMC part. Please join me as we welcome Dr. Mariam Abdullahi. Thank you. So, that is that about the contestant, the 15 contestants across the country. We'll now go on to welcome the assessors. Permit me, this is the third edition, the season 3 of the Shalina Rising Star program. These assessors have been with us through thick and skin. And some of the things we do today, we got those lead from them. And year in, year out, we get advice and how to go. And there are 3 musketeers, permit me to use that word. And we, more or less, we are still looking, we'll be discussing with our MD in Shalina how to also generate staff numbers, Shalina staff number for the 3 of them, because they'll be part and parcel of Shalina. Please, delightedly and reverently, permit me to joyfully start by introducing the assessors, starting with my good friend, my brother, my mentor, Professor Adamu Alhaji Samaila. He graduated from the famous Ahmadu Bello University's area with a Bachelor of Medicine, Bachelor of Surgery in 1993. He underwent the residency training program with the West African College of Physicians and was awarded the fellowship of the College of Specializing in Gastroenterology and Hepatology in October 2002. He was appointed lecturer in the Department of Medicine by University Kano in December 2002 and rose through the ranks to become a professor of medicine in October 2015. He has been an honorary consultant gastroenterologist in the Department of Medicine, Aminu Kano Teaching Hospital from 2002 till date. Professor Samaila underwent a one-year post-fellowship advanced endoscopy training at the University of Witwatersrand, South Africa, and the affiliate, Chris Ani Baragwanath Hospital, Soweto, Johannesburg, from November 2006 to November 2007. That was when he was hobnobbing with the late Mandela. He has more than 60 publications in peer-reviewed local and international journals. He has delivered more than 100 guest lectures, scientific papers, and seminars at local and international fora. His research areas of interest include gastrointestinal endoscopy, Helicobacter pylori, and functional gastrointestinal tract disorders, especially non-ulcer dyspepsia and irritable bowel syndrome. He is an external examiner and external assessor to many medical schools and Nigerian universities, and has been examiner with the West African College of Physicians for more than 2 decades. And currently, yes, for more than 2 decades, and currently serves as the quality assurance representative for the Faculty of Internal Medicine on the Faculty Board of Internal Medicine, West African College of Physicians. Professor is a recipient of several merit awards and a member of many professional bodies. Appointed as a consultant physician by Aminu Kano Teaching Hospital in December 2002, a position he holds till date. He is widely traveled across the world, married to a pediatrician, and blessed with 5 elderly children. Please join me as I welcome Professor Adamu Alhaji Samaila. All right, next, out of nowhere, delightedly again, I would joyfully introduce our delectable, erudite Dr. Afyong Oboko Oku. She's the Chief Consultant Community Physician with the University of Calabar Teaching Hospital and an Associate Professor at the University of Calabar Teaching Hospital. She's a Fellow of the West African College of Physicians, Faculty of Community Medicine. She holds a PhD in Public Health from the University of Oslo, Norway, and a Master's in Public Health from the prestigious University of Ibadan, Oyo State. Dr. Oku currently heads the Department of Community Medicine, UCTH, and UNICAL. As an academician, she has published over 40 original articles in many peer-reviewed local and internationally reputable journals, and has presented her work at both national and international conferences. She has supervised several master's and PhD students. She has also worked as a consultant to several international agencies, amongst which WHO, USAID, the Initiative for Equal Rights, Pathfinder International, CHAMPS, Nigeria, amongst others. Dr. Oku is passionate about training and mentoring the younger ones, especially young women, and ensures that she provides them with the right skills to excel. She also has a passion for teaching and transferring knowledge to her students, and always leaves a lasting impression on her supervisees and mentees. She's a 2-time award recipient for the best mentor trainer, organized by the Association of Resident Doctors, University of Calabar Teaching Hospital. Recently, just less than 2 weeks ago, she was awarded a meritorious award from the Vice Chancellor of University of Calabar as one of the 10 best heads of department in University of Calabar. Our research interests include health communication, maternal and child health, qualitative research, and health policy and management. She is happily married to Dr. Oboku Oku, and the marriage is blessed with 3 amazing children. Join me as I smile sheepishly to welcome Dr. Afyong Oboku Oku. And trust Dr. Afyong, she would always carry herself with that swagger. She walks majestically, and she will carry that swagger. You're welcome, ma'am. Right. Last but not the least, the intelligentsia. We have a reservoir. Someone that has distinguished himself, not just in Nigeria, but across the world. You need to Google this name. That is where you understand what I mean. Right. Please Join me to welcome Professor Stephen Odunayo Ikuerewo. He is a professor of urologic surgery and consultant urologist with the Lagos State University College of Medicine and the Lagos State University Teaching Hospital, respectively. He had his medical degree from University of Ibadan and graduated as the best student in the College of Medicine of University of Ibadan in 1997, winning many prizes and awards. His medical postgraduate training was at the University College Hospital Ibadan and the Medici Hochschule Hannover in Germany. He also won prizes and awards at the postgraduate level and was honored at the National Postgraduate Medical College of Nigeria. Since appointment at the Lagos State University, he has done highly impactful research and has published extensively on prostate and kidney cancers and general urology in several local and international journals. He has more than 65 publications to his name in reputable local and international journals. In addition, he has presented research papers and spoken at several conferences. He has successfully supervised at least 15 postgraduate dissertations for both the National Postgraduate Medical College and the West African College of Surgeons. Professor Ikuerewo popularized the operation of radical retropubic prostatectomy for early prostate cancer in Nigeria. Professor Ikuerewo enjoys traveling, taking a walk in nature, swimming, and watching football, even though Prof cannot play. He loves watching. Professor Ikuerewo is happily married and blessed with wonderful children. Please join me as we welcome Professor Stephen Odunayo Ikuerewo. He is also always gracious in his steps. Prof is also always gracious in his steps. Right. You need to engage Prof when you are in lawsuit. That's when you understand. He's always gracious in his steps. He speaks calmly and he speaks to the authority. So, on behalf of the management of Shalina Healthcare, I want to warmly thank everyone that is here today, the contestants that have traveled from far and near, and our regular panelists. And as I promised, that as much as possible, we will move fast so that we can make it, we can ensure that we spend very little time, but as well, make it interactive and very enjoying. So thank you very much, and wish all the contestants the best of luck. Thank you very much.
Thank you, Famayo. Okay, we know definitely that today is going to be a day of big words. A lot of big words already rolling out. Many times you wonder how doctors come up with those words, right? So, like there was the case of the man who went to, who had a condition, right? He noticed that every 8:50 a.m. and 8:50 p.m., he would have this severe pain in some parts of his body. And tried everything. Initially ignored it, then he started taking pain relievers, but nothing was happening. Then he started consulting doctors, and they didn't seem to be able to find anything or be able to diagnose his condition. So he resorted to traditional medicine, started taking agbo, what Yorubas call agbo. After a while, that still wasn't working. So he was told about this very weird, controversial doctor that he should see, that doctor can diagnose anything, that he should just go and see this doctor. So he went, booked an appointment, saw the doctor, explained to the doctor everything that was happening to him, and after his long explanation, the doctor says to him that, that's very simple. That's just a simple case of tendinitis. Okay, he didn't get it. So he was having the pain 10 minutes to 9, right? So it's tendinitis. All right, so we'll be hearing more of that. I've already picked one, otorhinolaryngologist. At times you wonder why they can't just say ear, nose, and throat. Am I correct? So without further ado, I'd like to call on the MD, Shalina Healthcare Nigeria, to take our opening remark and the official opening of this contest. Please join me to welcome Madam Opeyemi Akinyele.
Good morning, everybody. And standing on the existing protocol, I want to, with all pleasure, welcome you all to the Shalina Rising Stars Award, the 3rd edition. And I bring you best wishes and greetings from the global leadership of Shalina Healthcare, Shalina, Clifford, Abbas Verji, and Arun Raj. When you hear of big words like Benga said, like otorhinolaryngology, I mean, this kind of specializations, lay people like us would think of ENT. And you should just say, tell us ENT, and then we'll stop breaking our heads and racking our brains to understand what you're talking about. But then it goes a long way to show, to indicate what we have ahead of us, the interesting times we have ahead of us in the course of the day. The medical profession transcends the career path. It transcends building a career path, but it is indeed a response to the noble call to serve humanity. And we stand here today. This kind of event is to commend and applaud your response to this call as displayed in your various areas of specialization and the time and effort that you have invested over time in research processes that have led to your dissertation. This, indeed, we believe would, in a significant extent, impact our country's healthcare system and then impact humanity as a whole. And it is in alignment with our purpose at Shalina Healthcare, which is to make access to quality healthcare a right to every African in order for them to lead a healthy and productive lifestyle. And we want to appreciate the time and effort here, once again, that you have put into the selection process, which has brought you this far. And we believe that it is your dedication to the cause that has stood you out and is making, and has made you come here today and seated here today. We do appreciate you, and we congratulate you for being part of the finalists sitting in this room today. And on this note, I want to declare the event open. And once again, please keep the words coming. We'll learn. We're waiting with listening ears to hear more of such big, big words. Thank you.
Every person on Earth deserves to live a healthy life. Yet in many parts of Africa, people lack basic access to quality medicines they can trust and afford. Inspired to change this, Shalina Healthcare was established over 30 years ago, with a mission to provide quality pharmaceuticals that are readily available at affordable prices to those who need them most across the African continent.
Our mission to provide quality medicines that are affordable and available guides every decision that we make here at Shalina Healthcare. From which new products to launch, to the investments in our manufacturing plant, and to where to open a new distribution depot in Africa. We do this because real lives are at stake, and we are passionate about making a meaningful contribution in Africa.
With Africa's projected increase in population over the next few years, more and more people are requiring greater access to affordable, quality medicines. As a result, its pharmaceutical market is one of the fastest growing in the world. Shalina Healthcare has participated in this growth over the years to become one of the most trusted organizations in sub-Saharan Africa. With a diverse portfolio of market-leading brands, of more than 350 products across 12 therapeutic categories, trusted by both patients and doctors. As quality is a core pillar at Shalina, we source all our products strictly from WHO-approved factories and operate state-of-the-art quality control testing laboratories in both India and China to ensure the highest quality standards are met. Our facility in India has been accredited by the governing institution for every country we operate in and has the monthly capacity to manufacture 110 million tablets, 90 million capsules, 11 million tubes, and 4 million lotion bottles. Shalina medicines are registered in more than 15 countries across sub-Saharan Africa. Unlike most pharmaceutical companies, we operate an end-to-end supply chain with an expanding network of more than 30 Shalina distribution depots across Africa that supply directly to hospitals, clinics, pharmacies, and NGOs.
We're able to deliver quality medicines at affordable prices because we have full control of the supply chain from our own manufacturing facilities to our 30 distribution centers across Africa. Therefore, we cut out the middlemen and pass on these savings to our customers who are in effect buying directly from WHO quality approved facilities.
At Shalina Healthcare, it's not just about supplying a product. We strongly believe in the importance of getting involved with the community and providing support in every way possible to ensure a better quality of life. A team of more than 300 professionals organizes medical seminars, pharmacy meets, product presentations, and patient outreach initiatives, all in support of a better future. In addition, Shalina Healthcare provides education scholarships and donates to important initiatives such as building water wells, schools, and churches. With the growing demand for Shalina medicines, we are continually expanding our reach across Africa. But none of this would be possible without the passion of more than 1,000 dedicated employees who strive for excellence every day and believe in everyone's right to quality yet affordable medicines. At Shalina, we are committed to finding sustainable solutions for the long-term health of Africa, while always remaining true to our mission of providing quality, affordability, and availability. We are proud to contribute to making a better future for those in need.
Okay, next I'll call up the head of corporate marketing, Shalina Healthcare Nigeria, to take corporate presentation. It's just going to be 5 minutes, and then we'll start with the first round of the contest.
Good morning, ladies and gentlemen. Allow me to stand on the existing protocol. My name is Folorunsho Alaran. I'm a pharmacist. I head the corporate marketing and key account for Shalina Healthcare. And by the grace of God, I'm the lead convener of this rising star. Of course, with the support, hugely support of my colleagues here. It's a passionate thing seeing you steady here today because it's been some very tedious work the team has done to have gone around your various institutions and to see you fly high to represent your schools to be here today. I mean, if you see from, okay, when we get there, out of, we're intending to be like 30 schools. Sorry, I'm not saying schools, institutions. And we're able to get the responses from about 18, 20, then 15 materialized, 16 actually materialized. And that's what produced this. So really intend to actually do more. But notwithstanding still, It's work in progress, being season 3. And when I get to that high school, I'll let you know exactly what it is, what we are into. But before I do that, exactly what are we in Shalina? We've been able to show you a film clip of what we do as Shalina. We're a global, Afro-focused, multinational company. Have I done something wrong? Yeah, sorry for that breaking transmission. All right, in Shalina Healthcare, we inspire the world we are into. We believe that every African, like my MD rightly said, should have a right to quality healthcare delivery. And for us to achieve that, we believe strongly that we can actually be the health champions of Africa, and that we should actually contribute immensely to the health of Africans. And we do that only on some basic principle. We believe in our quality missions of quality product that we make affordable and to make them also very available across. Our goal actually is to try and touch at least 1 billion African. 1 billion African for a population of 1.2 billion. That's a very huge objective for us. And that's why when you see even what we are doing right now is in a bid for us to achieve that corporate purpose. And we are not going far. We are going so far in doing that. We are continuously innovating in the activities we do. And currently in Nigeria, we are not just the Shalina Pharma. We have the consumer arm. We also have the diagnostics. And we'll be reaching out to you more on those things. The whole idea is to see how we can be the health champions of Africa, how to get to be almost like a one-stop pharmacy to addressing the African needs more. Of course, this is heavily driven by a global experienced leadership team, one of them is amongst our MD in Nigeria, and CC is going to join us very shortly also for West Africa. And we started very humbly 40 years ago. This year actually marks 40 years of our operations in Africa. And from a small tiny shop in DRC Congo to where we are right now, it's been a long go, and we are now resting on our oars on the things that we do to get us here. So 21 African countries we are, and arguably one of the biggest pharma company in sub-Saharan Africa. 21 countries, some years back it was just 8. When I joined them some 6 years back, and we are not resting, we are trying to spread. The idea is to touch all African countries, touch 1 billion people, if we could do that. And you could see many of the companies that we have, we are actually brand champions. In DRC Congo, in Nigeria, we are number 5. Number 1 in DRC Congo and Angola. So we could see the strides we are taking. And it's just all due to your support that we're giving to us. But most importantly, for every step we take in achieving this, it's another assurance of all that we are nearing our goal in touching many more lives. Because the more countries we get into, the more lives we touch. The success behind this is not far-fetched. We control our value chain from our manufacturing facilities that we own, WHO-approved factories, to getting to the end users, your patients. We own those processes. So we are responsible for the quality of everything that we give. And by so doing it, we're able to control the prices so we can actually maintain that affordability aspect of our mission statement. So you could see many of our factories there, particularly the one in Nigeria, which is the very first African first factory we have in Africa, based in Nigeria, just here in Sherry. Last week, we were opportune and lucky and blessed to have the NAFDAC chairman, pay a visit, NAFDAC DG, pay a visit to the factory. And our comments were quite very encouraging in terms of the processes involved, probably one of the best we have in the country, and it's just technology transfer from the more developed countries that we came from. We have leadership in many of the brands that we do. So you'll be surprised what we're doing in Rising Star. We have taken selling to learning. We try to impact healthcare. There's more to which we can do, just making products available that are quality. We need to impact on the people that give those treatment, the HCPs, and you are there. So we'll do all these things to make you better. In this particular instance, maybe I could just jump the goal. We want to celebrate clinical practice. We want to celebrate researches that provide solutions so that outcomes can be improved upon. That's what we are doing. So we're able to serve the patients better. So these are the things we do across the countries where we operate. And so you will not be surprised. Apart from all these things, we have the CITA for the pharmacies, Shalina Academy, I'm going to go a bit later into that, and many of the partnership we have with many professional bodies. The whole idea straight is support what you are doing, serve those patients better. We are all going to be better for it. So for every single stride we take in our country, we have our team, we consult the Shalina expert panel. We want to be sure that what we are doing is in line with the expectations of the industry, expectations of the practice itself, so we can keep on meeting the needs of the patients, and that's what you see what we're doing. One of the other things we do global webinars, and we've done this a lot. We've done more than 25, with 10,000 ACPs joining in a single webinar. It might be across like 5 countries, Nigeria, Ghana, Kenya, Zambia. If you could recall, I'm sure many of my team members will have invited you to attend one of those webinars. We do that regularly as a continuous thing. So to see that we're actually concerned about, impacting on you. Beyond the online webinars that we do, we also have what we call the Shalina Learning Centers across all the locations where we operate. In Nigeria, in Ghana, Kenya, we have centers where you can come and actually have sessions of learning with assistants. We do that in-house and outside of the office as well. So we keep on doing all that. So learning to capacity, we do so many things. We do sign-ups. Recently, we introduced the Shalina Medscape, where you can go get any resource that you want on any specialty that you want to support your, we do all that. So many of things we do. Recently also, we introduced the Antibiotic Stewardship Program. We found out that that's a very that actually is lacking in Nigeria, the guide to getting a protocol in place for effective use of antibiotics. We do that, and we have the panels are across the 6 geopolitical zone, and we are going very far. The documents are ready, and we are at the stage where we are stepping them down now to the different health centers too. So many activities that we do that promote things. Most importantly, touching the patients as well, we have what we call the Shalina Market Clinics. So if you see all these things, beyond many pharmaceutical companies that will probably do, coming on your door, knocking on your prescription and everything, we give back. We try to support, touch the lives of Africa, and we are very passionate about what we do. So these are some of the activities we do. The online certification for pharmacists, the online certification for medical doctors, and many things. And of course, one of them is the reason why we are here today. That is Shalina Rising Star. Once again, I want to say thank you for competing. I understand that some people probably sent in their dissertation. You are here because your dissertation happens to be the best across the interdepartmental competition that we held in your institution, which we call the Day of the Rising Stars. In some centers, we have up to 10 people contesting. Some 5 dissertations they presented through the local panels, and they selected you as champion. So what is Rising Star basically? Our idea actually is to provide a platform where you can actually have a way to interact with yourselves. And it's a simple thing. You need a platform for medical professionals to showcase their clinical talents. And we're asking you back then if you were ready. But apparently you were more than ready, because that's why you are here now today. We are glad that you could make it up today, basically. So the grand prize for this session is ₦1 million. And I will tell you what has changed. In season 1, we started with case reports. Then we had to approach the ALD session, where we get some special cases sent in across. We work very slowly, very strongly that time with National Association resident doctors. In season 2, we did the same thing. Then it came to us that instead of taking the case report, we want to take something that can actually offer more solutions. And we're like, okay, good. Maybe researches and dissertation. And that's why it seems that it's limited now to young fellows. And we also pen the number of years to 1 year just being a fellow. And I know that automatically those people here today are consultants in their various fields. So question is, what is the import or objective and the impact your researches are made? And that's actually what we are interested in. And of course, many people here, irrespective of whatever department or specialty they are, they will be concerned about that your solution that you've offered through your dissertation. So it was a day of rising stars, agreed. And I want to give special thanks to your different management, meeting the CMD, my team across, our colleagues across the different region. We sent a lot of letters to more than 30, but only about you, got back. It was not so easy to agree on the date with the hospital management. It had to be organized by the CMD, by the CMAC, to fix us a day, to put all the HODs together, to agree on one day to do that. And we're able to successfully do that for about 20, Barao Digo, for instance, they are not here. The day we fixed started to be started. That when the bomb blast in Cardinal started. and they could not just do that. They had to honor the death and cancel that. So they might probably be hearing us because this session is being viewed across. We give our support to them. We understand that they could not do that. So we are here because of that. And the different management, thank you very much. So it's a two-stage thing. We have the institutional level where we had the Day of the Rising Stars, which I said earlier. And of course, it's a step thing. We didn't do any regional category, my panelists. We were told that there is no barrier, there should not be any regional barrier to science. Maybe if you have done zonal qualification, maybe the person that has lost out in the particular region might be better than the best in another region. So we decided to bear the cost and let all the champions come to Lagos and let's see what science to come out to. And that's today. So all of you here are, your champions in your various schools. From memory, we did the first one. Dr. Olalu of FMC was the first winner 3 years ago, and he got the same grand prize of $1 million. And the second last year, Dr. Taiwo of University of Abuja Teaching Hospital. Of course, there is someone from Abuja Teaching Hospital. Yourself? Okay, so she's the second winner in our year 2, and now we are in the 3rd season. We are saying who will the cap fit. So the next task I have is to show you the road to this grand finale, how we were able to go around your various institutions. I want to show you that. Thank you. Join me on this trip.
Okay, that was the first 5 minutes.
Don't mind these people. See, it's okay. I won't take too much time on this. We started this like 3 months ago, precisely November, when the first actually. So we're able to cover these various schools. So the various institutions that you're seeing on the screen. Again, I want to lay on the behalf of the management of Shalina Healthcare to thank your various management for agreeing to take on those days and running those things. We were just on the side. They ran the show and gave us the champions that we're looking for, who are competing today. All right. So we started. 175 dissertations were presented, and we had 17 winning along the way, but 15 are here for other reasons. So we started with FMC Bida back in 6th of December. We moved down to 11 to FMC Ebutemeta. Then we are in FMC Asaba, where Dr. Saze won. Went to Abuja as well on the 21st of December, where Dr. Saze Ugege won plastic surgery. We were in University College Hospital on the 22nd of December. It's actually a Saturday that we actually held it in UCH, and that was Dr. Malaria Oluwadare emerged as the winner on that day. Then we moved to Calabar on the 24th of January after the New Year, the very first one we held when the New Year started. And we, of course, our dear panelist was able to, having had experience on the first and second, was able to help us coordinate the Day of the Rising Star. And then we have Dr. Samuel Akpan with us today, who emerged the winner in that session. Then on the, we moved from there to university. On the same day, actually, it was also happening in the River State University Teaching Hospital on Hospital Road in Port Harcourt, where Dr. Ikiruma, emerged as the winner. Then we moved to University of Port Harcourt, 26th of January, for Dr. Onumako Isioma of Pediatrics, came up as the winner on that session. Then came the 30th of January, we went to Aminu Kano Teaching Hospital, the home base of Dr. Samaila. And Dr. Miriam Abdullahi emerged as the winner, and she's here with us here today, in ophthalmology. Then we also moved to, next was the Federal Teaching Hospital in Katsina, where we had Dr. Kelani Suleiman of Microbiology Department emerging, having the best dissertation for the institution, and he's also here with us today. After that was University of Benin Teaching Hospital on the 9th of February, Dr. Ufedima Lawani, they can't be family dentistry, family medicine. Am I right? Family dentistry. Wow, interesting. Well, we have a lot to learn here today, actually. Thanks. So glad to have her with us. Yes, you're welcome. All right. The Day of Rising Star moved to Nnamdi Azikiwe University Teaching Hospital on the 22nd of February, where Dr. Nwafọ Ifeanyi Echezona won from the ENT. Then the day register moved to University of Nigeria Teaching Hospital with Dr. Maduka Collins, GDO4 of Hematology. We also moved to Lagos University Teaching Hospital. We were a lot of going forth and back. Eventually, we were able to get a date for last suit, and we held it. Thank God for the team. Dr. Malaria Odusi emerged to be the best, with the best dissertation on that day. Then University of Youth Teaching Hospital held some days after that on 22nd of January or February. And finally, after much, we were able to hold the one for National Orthopedic Hospital, where we have my good friend, Dr. Aikomen Oswan Hele, here with us. I hope I didn't destroy your name. Oh, thank you. All right, so we're very glad to have you. But the question is, this is the road to the channel, to the final, and we are here to contest for the grand prize. We know there have been a lot of solutions. People here are very eager to see how impactful your researches have been, and they can take a lot of learnings from that as well, irrespective of which specialty. That's what the program is now offering. Either way, you have a lot to learn. So a reason for us to pay. And I can tell the audience too that we are prepared for you. There will never be a dull moment. There will never be a dull moment. We can approach. So who does the cap fit? Thank you.
Thank you. All right, so let's get ready to rumble, like they say in wrestling. All right, we're going to start with the first round of the competition, which is basically the presentation of the various dissertations here. Like you heard, they are consultants. They've worked hard on these researches. They're going to present their researches, and we have able and capable members of panel to guide us through this this session of the competition. Of course, we'll be calling up the competitors, or the contestants rather, one after the other. In no particular, or is there a particular order, Chuba? In no particular order. So once you you hear your name, then you come up with your presentation. Over to you, panel of judges.
Hello, good afternoon, everybody, and welcome to the season 3 of the Shalina Rising Stars 2024, the grand finale. Well, as been described, you see the people that we have here, they are winners already, from their different institutions. So this is just like the Champions League final, Yeah, so the today's activity is going to be in 2 sessions. One is the presentation of your dissertation, which is going to take 80% of the mark. Then the lighter one, which is the rapid fire quiz competition, that will take 20% of the mark. Okay, so we're going to assess based on this. So I think we start the presentation. Each presentation will be for just 5 minutes. Okay, just 5 minutes, and you must keep to time. If you don't keep to time, it's negative mark. Okay. So, and then we will have 2 to 3 minutes for 1 or 2 questions. And then we are also going to score you on how you respond to those questions. Okay? And that is the process. So, basically, that is what we're going to do in the assessment. So, after the first round, I think we will have the first 8 presenters now. And then we take about 5 to 10 minutes break to stretch our legs and all that. And then we'll come back again to have the remaining 7 or 8. Then after that, we'll have a brief rest again. And then we then have this second portion, which is the rapid fire quiz competition, which is just to make things brighter for us, but at the same time, we will score you on how you perform there. So thank you. I think we can start right away. Thank you.
All right. Thank you, sir. So we're going to start right about now. We'll be calling you up one after the other. You have 5 minutes, as has been said. You have 5 minutes for your presentation, but we're going to help you after the 4th minute, you're going to hear a clap on the mic, which indicates that you have just 1 minute to round off the presentation. All right, Chuba. So our first presentation is from Dr. Oluwadare. A round of applause for him, please.
I think the timing should start from the first mention, the first word of your dissertation. Once you say the first word of your dissertation, timing starts.
This is forward. Okay. If you need to go back, use this one. This is next time. This forward.
You don't waste time to introduce yourself. You've all been introduced. Just go straight to the point, please.
Good morning, everyone. My title of my work is Clinical Epidemiology and Geospatial Distribution of Cases of Severe Malaria in Children seen at the University College Hospital, Ibadan. I'll be following this outline. Sorry. Malaria is an ancient disease, and it remains the disease with most significant epidemiologic and socioeconomic impact in sub-Saharan Africa. Nigeria accounts for 27% of the cases of malaria and 31% of the mortality. This means that 1 out of every 4 cases of malaria in the world is from Nigeria, and 1 out of every 3 deaths due to malaria is likely to be from Nigeria. Before now, the burden of disease has traditionally been in the under 5s. However, there's beginning to be a change in the trend, and that's the essence of this study. It was an analytical cross-sectional study that involved children aged 6 months to 15 years who present with features of severe malaria according to the WHO criteria. It entailed collecting clinical information about the children, their socio-demographics, and laboratory parameters using a semi-structured interview-administered questionnaire, and then investigations like blood film for malaria parasite and rapid diagnosis that were done, and using geographic information system, which is the core of geospatial technology, others being global positioning system and remote sensing, I was able to generate a severe malaria risk map. Summary statistics was presented using frequency tables and bar charts and measures of central tendencies. For factors that were independently associated with outcomes, I used multinomial logistic regression to evaluate such. There were a total of 165 children, majority of whom were under 5s, giving a ratio of 1.3 to 1.0 in favor of the under 5s. This means that if the children were subdivided into groups of 5, for every 3 under 5 children, we had 2 children that were in the older age group. And then the most common presentation of severe malaria that was identified was prostration. And this is a deviation from the usual severe malaria anemia and cerebral malaria that had been observed in previous studies. I also noticed that residents close to water bodies and increased nighttime light were significant risk factors for severe malaria. This map shows the distribution of cases of severe malaria in Ibadan. There are 11 local governments in Ibadan, and 5 are peri-urban, 5 are urban. Sorry, this thing is not showing. 5 are urban, and then 6 are peri-urban, making a total of 11. Now, the dots we can see, they are referred to as point features in geospatial parlance. And then each point represents each child. If we were to count, we will not get exactly 165 because there are some overlapping. The area that is darkly shaded is where clustering occurred. Clustering is said to happen when a phenomenon is observed more frequently than can be attributed to by chance. And this is seen in the middle, that's around Ibadan North local government area, minimally in Ibadan Southwest, some in Onwara local government areas, and in Egbeda local government area. Now, the summary of this line graph, simply put, is that the closer to water body a child is, the higher the risk of malaria. If you look closely, up until there was a steady increase of severe malaria cases, up until 200 meters from water body, then from 300 meters, there was a sharp decline. Now, if you cumulatively had them, half of the children live within 200 meters of water body, 3/4 of the children live within 300 meters of water body, and then there was a subsequent decline. Now, this map shows the nighttime light pattern in Ibadan. Now, the areas darkly shaded are where we have increased nighttime light. And there's a proportion that light is an insect attractant, and therefore, where you have more nighttime light, the children are likely to have, we have more cases of severe malaria there. Now, although the burden of severe malaria is still borne largely by the under 5s, the children in the older age group are becoming more susceptible. And this is foreboding in the sense that there's more school absenteeism, there's suboptimal neurologic attainment, and then more of the gross domestic product of the nation being spent on malaria. Nigeria cannot afford to add this burden to its teeming challenges. Younger age and multiple severe malaria features predispose to poorer outcome. And my recommendation is that intervention measures that focus on the under 5s should be sustained and extended to the older children. Take home point: malaria is a hydra-headed monster. History shows that malaria disappears and then returns. Therefore, its elimination and eventual eradication requires multiple efforts, decisive, cohesive, and a concerted effort from all stakeholders, including you, my esteemed listeners, and me. These are some of my references. My teachers, thank you for listening.
Thank you very much, sir. We'll move on to the next presentation, which is...
No questions.
Oh, sorry. Apologies. A couple of questions from the panel.
2 minutes for questions.
Okay, all right, sir.
Not from the panel, from anybody.
Oh, okay. So, any questions from the floor?
Okay,
definitely
questions?
not from the contestants. Any questions from the floor? Okay, none?
Judges, can you? Okay.
Tell us the exact sampling method you use in this and how you arrive at the sample size. Thank you.
Thank you very much, sir. I used a non-probability sampling technique, which was a consecutive sampling method. Children with severe malaria that according to the WHO criteria for severe malaria, that had features were consecutively recruited until the sample size was attained. Thank you, sir.
Thank you. That's all.
So would you consider that an appropriate sampling method for this study? I'm just asking. What would you have used and why?
Thank you very much, ma'am. Because it was a non-probability sampling method, there was some degree of bias that was introduced into it. But because of the title, Clinical Epidemiology and Geospatial Development of Cases of Severe Malaria in Children, already my title had decided on the number on the children. They were going to be children within a particular age group, 6 months to 15 years. 15 years is the peak of age that we admit children in at the hospital Ibadan. So that's why it was more. That's why we had to use a non-probability sampling method. But ideally, to remove bias, it will have been a probability sampling method where we can use simple random sampling technique or multi-stage random sampling technique.
So the implications, just for learning purpose, the implications that your findings may not be extrapolated to other sites because of your sampling methodology.
Yes, ma'am. Actually, because
so that's the limitation.
Yes, ma'am. It wasn't manual, but I couldn't project that because of time.
All right, thank you so much. Next.
A round of applause for him. Thank you very much. Next presentation is by Dr. Uduola Owo, Padmos Baba today. A round of applause.
Good morning, everyone. I stand on the existing protocol. The title of my dissertation is Efficacy of tranexamic acid in reducing blood loss during cesarean section, a randomized double-blind controlled multi-center study. We will all agree with me that in the next 5 minutes, globally, 2 to 3 women are dying of obstetric cause, and majority of those deaths are due to obstetric hemorrhage. So if there's anything to do to stop or reduce the incidence of obstetric hemorrhage, it has to be done to the fullest. Statistics are there to show that Sub-Saharan Africa contributes the whopping 60% of the global maternal mortality, and in Nigeria contributes 15% of the global maternal mortality that is made up of just 2.6% of the population. Primary postpartum hemorrhage varies widely in incidence, and also to know that cesarean section has moved from being a death sentence to an alternative to delivery that is sustainable and here to stay. Tranexamic acid is a potent antifibrinolytic agent that binds avidly to plasminogen and prevents it from converting to plasmin, which now prevents the degradation of fibrin. There are studies that has been elucidated of this potency. However, no woman should die from the responsibility nature has placed on her, which is one of the main justifications for this study. Having known that there are few studies that investigated the usefulness of tranexamic in preventing primary postpartum hemorrhage, and no similar study has been done in this center before. My aim is to assess the efficacy of tranexamic acid versus placebo in reducing blood loss during cesarean section. And my objectives are as follows. My low hypothesis and all are as follows. And this study was done in Federal Medical Center, Butemeta, and Lagos University Teaching Hospital, Ikeja House, in Department of Obstetrics. And the population were all consenting women admitted for elective emergency cesarean section in both these institutions. The study design was that of at the antenatal clinic, patients were counseled on the study and investigation. Counseling was reiterated at the point of admission, and each woman that consented to participation was signed an informed consent. This study took a period of 9 months. The randomization was blood-blinded placebo-controlled study. Randomization was centralized, stratified, and balanced in blocks of 10. Codes were generated by the Red Cap Research Studies. Sequencing, generation, allocation, consumption, implementation, and blinding were done by seasoned pharmacists. This is my sample size calculation, which calculated 65 participants in each arm with 10% attrition. And the intervention was to receive intravenous tranexamic acid within 3 minutes of delivery. Calculative method was used to estimate estimated blood loss and also visual estimation, and the inclusion and exclusion criteria were as follows. Data was analyzed using the IBS and ethical consideration was considered. This is the chart flow of the randomization of 65 participants in each arm. And my result states that there is no statistical difference in the characteristics, based on characteristics of participants in both study arms. The obstetric and surgical characteristics in both arms were not statistically significant difference. However, the obstetric characteristics were not significantly different. However, I found that the postoperative blood loss was higher among the placebo group compared to the intervention group, and the p-value is there to show. The mean postoperative blood loss was 347 mils higher among the placebo compared to the intervention unit, which is statistically significant. Also, the prevalence of postpartum hemorrhage, among the placebo was 4 times prevalence in placebo group. Wow. Also, univariable and multivariable logistic regression was done to take care of confounders, and there is difference between the postoperative and the preoperative hemoglobin, which is higher in the tranexamic acid group. In conclusion, the box plot also shows that the difference in the hemoglobin is higher. The side effect profile is the same. And in conclusion, the study found statistically significant difference in hemoglobin change reduced in blood loss, lower prevalence of postpartum hemorrhage in participants in the tranexamic acid group. There's no significant difference in the placebo group. Recommendation is prophylactic use of intravenous tranexamic acid as an adjunct to oxytocin at cesarean section, reduce blood loss, and prevent primary postpartum hemorrhage has been recommended when not contraindicated. Thank you very much.
Thank you.
These are my challenges.
Questions?
This question for the presenter. What statistical method did you use to compare the two groups? What statistics did you use to compare the group and the placebo?
Okay, sir. The continuous variables, I use the Z test and T test, while the categorical variable, I use the Fisher's extract and the chi-square.
Thank you very much. You know, there was a woman trial.
Yes, sir.
That has already documented the efficacy of tranexamic acid in vaginal delivery.
Yes, sir.
Now you are looking at the effect of this same drug on women undergoing cesarean section.
Yes, sir.
Now, don't you think there's an ethical issue to leave a woman on a placebo, denying her a drug that you know will relieve postpartum hemorrhage? What were you giving as placebo? Because wouldn't it have been better if you compare the same tranexamic acid, but you recruit other women that were having vaginal delivery, which is established by the woman trial, and then cesarean section, whether you see what the effect of the mode of delivery that is the effect.
Yes, sir.
And what were you giving as placebo? No more saline or what? Because it has to be something that resembles what you are giving. So what did you prepare in your center as looking like tranexamic acid, even label everything? All the doctor doesn't know is placebo. What were you giving? Or it was just nothing given to them? Thank you.
Thank you very much, sir. Yes, it's a placebo, double-blind placebo trial, and it was water for injection, sterile water for injection, and the use of tranexamic acid in this study is an adjunct to uterotonics. It's an adjunct to uterotonics, and prophylactic use is what is the outcome in which I intend to measure as an adjunct to the normal uterotonics that was used. So uterotonics were still used, which will prevent postpartum hemorrhage in them, but an adjunct was added, which gave me the findings of the study.
Okay. Last comment from my end. I see you've registered in the Cochrane.
Yes, ma'am.
You registered the trial. Have you updated it?
Yes, ma'am, I have.
Okay, and then lastly, I saw you had 100% loss to follow-up. So you didn't lose any patients in the course of these experiments?
No, ma'am.
So all patients that started the study with you ended the study?
All the patients that were for elective and emergency cesarean section
ended up?
Yes, participating in the study. Okay. Yes, ma'am.
Okay.
Thank you, ma'am.
Thank you very much.
Thank you.
Next.
All right, next presentation is by Dr. Ikroma Sokepirim. Sounds like the name of, sounds like Emprim is a drug. A round of applause for him.
Sorry, that's number 4 on the on that order, Abi. Okay, thank you.
Number 4.
It's okay. It's number 2. It's okay. 1, 2, yeah.
So please, when you are calling them, since we are not going sequentially,
let's know their number.
You know the table number so that we will align it.
All right, sir. Yeah. Noted. So first presenter was number 1, number 2, now number 4.
Okay, thank you very much. My dissertation was titled A Comparative Study of Single versus Dual Agent Antibiotic Prophylaxis for Elective Cesarean Section at the River State University Teaching Hospital. Now, we all know that cesarean section is a frequently performed surgery. It's the most common obstetric and the most common major surgical procedure done worldwide. Like any other surgical procedures that are done, there are complications which may affect the health of the mother, the health of the baby, as well as affect future pregnancies. Now, surgical site infection is the most common form of post-operative morbidity and a major contributor to mortality across all surgical disciplines, especially in low-resource settings. And it's an important determinant of the success or failure of surgical practice. Surgical site infection can be prevented by good surgical technique, patient risk factor optimization, as well as adherence to aseptic protocols. However, but the use of antibiotics have been a major contributing factor to the reduction of the cases of post-cesarean surgical site infection. Now, We all know that antibiotic prophylaxis is universal. There are differences, however, that exist according to obstetricians' preferences, and this has led to debates regarding the choice of antibiotic, the dose of antibiotic, the duration of antibiotic, as well as the timing of antibiotic therapy. Thus, there exists single agent, single dose, single agent, multiple dose, multiple agent, single dose, multiple agent, multiple dose regimens. These varying approaches, despite lacking informity, has led to a drastic reduction of cesarean section surgical site infection. However, without a standard policy or evidence-based guidelines, non-informity, irrationality, and inconsistency in the administration of cesarean section antibiotic prophylaxis has become widespread. Now, irrationality of antibiotics can increase healthcare costs, increase risk of drug-related side effects, increase nursing time, as well as increase the risk of development of antimicrobial resistance, which is a huge problem in the world currently. In my center, there's no protocol for the administration of antibiotic prophylaxis during cesarean section, and there are also no studies that have been conducted in this regard. It's a common practice for women that are undergoing cesarean section to receive multiple doses of 2 to 3 antibiotics for varying periods of even up to 5 to 14 days, depending on individual obstetrician's preferences. Some of the women are unable to afford the full cost. Some report drug-related side effects. Some are unable to maintain compliance due to the multiplicity of antibiotics and the prolonged dosing duration. It's along this line that my study was formulated and carried out so as to provide an evidential basis for the use of antibiotics during cesarean section, as well as to draw local and regional attention to the promotion of rational antibiotic use in obstetric and gynecology surgeries. Now, the aim of my study was to assess the outcome of single-agent third-generation cephalosporin versus dual-agent combination of a third-generation cephalosporin and metronidazole in the prevention of, in the provision of antibiotic prophylaxis for elective cesarean section in low-risk women in my center. Now, the objective is to compare the incidence, to compare the mean cost of treatment, as well as to compare the incidence of side effects with single-agent versus dual-agent antibiotic therapy. Now, my study was a single-blind, it was a double-blind randomized control study that was carried out at the Department of Obstetrics and Gynecology in my center. The study involved 60 consenting eligible low-risk women who were admitted for cesarean section for various indications. The study participants were randomized into groups of 30 each, and by simple randomization, and these groups are labeled A and B. A represented single-agent third-generation cephalosporin, and B represented a combination of third-generation cephalosporin and metronidazole. The preoperative preparations were standardized in both groups. Now, after the surgery, the participants received the antibiotic according to the various protocols, and we assessed day 1 on admission using the standardized patient chart. The surgical wound site were expected on the 2nd and the 4th day, and the patients were discharged home on the 4th day if they are deemed fit for that. Following discharge, patients were seen in the outpatient clinic on the 14th and day 14 and day 30, and were discharged from the study after day 30. Now, the data obtained was entered into a spreadsheet and was analyzed using IBM SPSS version 22 for Windows. The results of categorical variables were summarized in tables as frequencies and percentages, and the results of numerical values were summarized with means and standard deviation. Hypothesis testing using the independent t-test and the chi-square test was used to assess the level of significance and difference in the outcome between both study groups. And the data analysis revealed that the two study groups are similar in their baseline characteristics. The total surgical site incidence over the period was 8.3%, and the difference was statistically significant. Data analysis also revealed a statistically significant difference in the mean cost of antibiotic, and also even in the incidence of side effects. Now, In conclusion, my study revealed that as in the single-agent third-generation cephalosporin was found to be as effective and as cheap as a dual-agent combination of third-generation cephalosporin and metronidazole, intravenous ceftriaxone and metronidazole in the provision of antibiotic prophylaxis against surgical site infection in low-risk women undergoing cesarean section at the Rivers State University Teaching Hospital. And also my study, the conclusion drawn was that the dual-agent antibiotic use was associated with a high incidence of side effects compared to single-agent, even though these effects were mild. The recommendations from my study was that as in, it has been recommended that the use of single agents be considered for routine use. Thank you very much.
Georgie, questions?
Thank you for your presentation. Can we have questions for him? Anybody has any question for him, please, from the crowd? Yes, please. Microphone to him. Please make it very short.
Generic branded brands, and did you use if generic one for the second, or you use different brand for one and then generic for the other, and what could be the effect of your research?
Thank you. Any other questions? Let me just ask, on what basis did you choose the antibiotics that you compare? On what basis?
Okay, the antibiotics are chosen.
Let's finish. Because it's similar. Also, you are giving single agent third generation from anaerobe. Already you have introduced, because that's what I already advanced, the same third generation, you're adding another and another to the other group. And you are giving some IV, then the other one is oral with this. So bioavailability already is already ab initio. It's already bio because you expect IV to be more effective bioavailability. Thank you.
So the last question, what are the possible confounding variables in this study?
The type of surgeon. The surgeon that did it, he analyzed that.
And any patients on prolonged obstructive labor, all those stuff and all that, yeah.
I will start by answering the last question. The preoperative preparations were in both groups fairly standardized. All patients had their bath on the morning of the surgery. The surgery was both done in the same theater complex, and all women received a standard surgical antibiotic prophylaxis, a gram of ceftriaxone, 30 to 6 minutes before the incision. And consultants, senior registrars, were performed all the cesarean sections of the study. Dilute chlorhexidine and alcohol were used for skin preparations. In both study groups, it was the same process for both study groups. And the antibiotics used for the study, it was the same for both study groups. In the group A, they had third generation. The study participants in this group, they received intravenous ceftriaxone for daily, 1 gram daily for 48 hours, followed by oral cefixime, 400 milligram daily for another 72 hours, total of 5 days. While the study participants in group B received both ceftriaxone, a gram daily for 48 hours, and metronidazole, 500 milligram, 8 hourly for 48 hours, followed by oral cefixime and oral metronidazole. Both antibiotics, as in both the same antibiotics was used in both study groups, as in there was no sponsorship, so there was no conflict of interest in the choice of or in the brand of antibiotics. The brand of antibiotics used represented a fair choice between availability and affordability and quality.
Thank you.
Thank you very much, sir. Okay, moving on to the next presentation. Presentation by Dr. Maduka Collins, contestant number 5. A round of applause for him, please.
Good afternoon, all. The title of my dissertation is Assessment of Steady-State Levels of Interleukin-15 and Interleukin-17 as Indicators of Severity in Patients with Sickle Cell Anemia and their levels during vaso-occlusive crisis. This topic was actually inspired by the recent discovery that sterile inflammation is the very core of the pathophysiology of sickle cell anemia, and also by the fact that despite the burden of sickle cell anemia in the world, there is no consensus severity assessment score for these patients. These are my outline. The aim of the study was actually to evaluate the levels of these inflammatory cytokines in sickle cell anemia patients, divided into those with mild disease, those with severe disease, those in vaso-occlusive crisis, and also their levels in the healthy controls. The justification behind this study is overwhelming. Presently, sterile inflammation remains the very core of the pathophysiology of sickle cell anemia. As a matter of fact, it's so celebrated that a lot of drug companies have created drugs targeting offshoots of this pathway. These are drugs include incanglumab, crizanlizumab, all targeted, utilized in the management of sickle cell anemia at the present. So the question is, why don't we get to the core of these? And also, coupled by the fact that Nigeria remains the habitat and remains the country with the highest burden of sickle cell anemia in the world. The study design is basically a prospective constructional study that assesses the effects of interleukin 15 and 17 in sickle cell anemia patients as a measure of their disease severity and their levels during post-occlusive crisis. A total of 136 participants were enrolled in this study, and the sample size was calculated using sample size for 2 means. The methodology basically involved the use of chemiluminescence ELISA method, in which 2 antibodies, one trapping the cytokines, the other one attached to a chemiluminescent agent that changes color from colorless to blue, eventually to yellow. And this color is This color is assessed using a spectrophotometer. And the spectrophotometer will show the varied optical densities of this cytokine. And a graph is plotted using their optical densities with the concentration extrapolated from this graph. Data analysis was done by IBM Statistical Package for Social Sciences. For the core cytokines, I used the Kogrobo-Spedov analysis, and I noted that the data wasn't normally distributed. I used the Van Whitney U test for assessing two groups, while I also used the Kuskowali's test, H test, for assessing 3 groups. While Peptic correlation was used to compare the relationship between these cytokines in mild and severe sickle cell anemia. I will discuss the results with the discussions together because they go hand in glove. In the discussion, it was found out, I found out that there was no statistical significant difference in the cell levels of interleukin 15 and 17 in adult LCA subjects in steady state compared to healthy controls. No significant difference exists in cell levels of interleukin 17 in adult LCA subjects in steady state when compared to healthy controls. And there was no significant relationship between steady state cell levels of interleukin 15 and 17 in subjects with mild and severe disease. Also, there was a statistical significant difference in several levels of interleukin 17 in adult ACA subjects in steady state compared to VOC. Also, no significant difference exists in several levels of interleukin 15 in adult ACA subjects in steady state compared to VOC. The recommendations from these studies included these. Further studies employing larger sample size should be carried out to collaborate the findings of this study. Further sample studies employing assays for interleukin 17 and 15 mRNAs should be carried out to collaborate these. More inflammatory cytokines like interleukin 23 and 32 should be assessed if they can act as indicators of severity in LCA subject with vaso-occlusive cancer in steady state. And also further studies employing cohort model would show long-term changes in variables of these cytokines and improving outcome of the study. Thank you very much.
Can we have questions for him, please, from the audience?
Please, can I sit down?
Dr. Daniel.
Thank you. Well done. I just wanted to know, how did you determine severity in these patients with sickle cell anemia? Because I thought your objective was to see whether the interleukins, determined it. So clinically, how did you do that?
Thank you very much for the question. Severity was I used the study by Okocha et al., which was also done in Nigeria here among adult subjects to determine severity. He used the parameters involving the full blood count, clinical features to determine severity. And in determining the severity, it was ranked that those with comorbidities or sickle cell-induced disorders like chronic leg ulcers and nephropathy were ranked as 2, while using the full blood count, patients with HB 8 to 10 were graded 1, those with HB 6 to 8 were graded 2, and those less than 6 were graded 3. For the white cell counts, those sickle cell patients having below 9 times 10 per 9 cells per liter were graded 1. Those having between 9 to 12 were graded 2, and above 12, above 12 was graded 3. And in the summation of these determining factor, Ranges between 0 to 1 was graded as a mild disease, while ranges above 5 was graded as severe disease.
You know, her question, not assessing the severity of the sickle cell anemia, but severity of vaso-occlusive crisis. Hemoglobin level, or that is you are giving nephropathy. It's talking about the VOC. That's what you are. So okay. It's the severity of, how did you assess the severity of VOC?
Severity of the disease. Yeah. Any question?
No, somebody there.
Well, Doc, thank you for the presentation. I must tell you that this is a novel study. And I must say that it improves our understanding of the pathophysiology of sickle cell disease. But what I'm wondering is that why the choice of interleukin 15 and 17, when there are when there are arrays of interleukin cytokines that are involved in the pathogenesis and pathophysiology of sickle cell disease? That's number one. Now, number two, why the choice of ELISA technique in your assay? Why not radioimmunoassay? Why not mass spectrometry? Then I can see in your recommendation you said more studies should be done. I agree with you because this is a novel study.
Okay. Thank you very much for the question. The choice of cytokines, yes, there's an array of inflammatory cytokines, but it has recently been discovered that interleukin 17 is the chief orchestrator of chronic inflammation involved in sterile inflammation, with interleukin 17 supporting the effect of this interleukin 17. If I'm opportunity to go further to describe it effectively for you, interleukin 1 beta, interleukin 6 commences this process of inflammation, then inducing type 17 T cells to produce interleukin 17. This interleukin 17 produced now in the presence of interleukin 15 commences this process of chronic inflammation by self-induction. Thus, once it is produced, it has a positive feedback effect, such that even when these sickle cell patients are in supposedly steady state, they are having this process of chronic inflammation ongoing. That's why it's stated that sterile inflammation is able to track variables in sickle cell anemia, like the clinical presentation, the number of crises they have, and the varieties in the white cell count they present with, even when they are not having crises.
All right. Okay.
Just a comment. Your study design, you said prospective cross-sectional study. I just want to correct you. So what you did and what I listened to was a comparative cross-sectional study, analytical study. Yes, okay, not prospective cross-sectional.
Okay, ma'am.
Thank you.
Thank you, ma'am.
All right, a round of applause, please. Thank you. A particular round of applause for him. You could see that he was experiencing some little discomfort while he was doing that presentation. Well, Prof said we'll check his interleukin 17. How many of you who are not doctors here actually suddenly felt you were in church at a particular point in time? Like speaking in tongues and all that. Okay, so moving on. We have Dr. Igwage Osaze Ude. Welcome, sir.
Good afternoon, all. My dissertation was to compare calcium alginate with povidone iodine to over split thickness skin graft donor sites. The procedure of skin grafting is a common procedure we do in plastic surgery, and that involves taking skin from an area of the body, which we normally would call the donor site, to resurface a defect somewhere else in the body that has a wound, which we normally would call the recipient site. This study actually entails the fact that there has been a lot of work done on the dressings that we use in donor sites, for which calcium alginate and povidone iodine is a common dressing. However, in our sub-region, calcium alginate is not a dressing that is in common use. Now, the reason is why, and the literature has itemized several benefits behind the use of this dressing. So in order to answer this question, was the indication for this study. My aim was to actually find out the outcome between these two dressings, with specific parameter of interest being pain, background pain that the patient will have, or pain during dressing removal. Then infection and time to revitalization. Time to revitalization, I actually mean wound healing. Now, my study was a hospital-based randomized study that was done at the University of Abuja Teaching Hospital. The sample size determination was using a formula to compare means with where the endpoint is qualitative. The sample technique was just a simple random sampling method using an app called Calculator.net that helped me in dividing these patients into two groups, the calcium morginate group and those in the povidone iodine group. These were my inclusion criteria and the exclusion criteria for the patient that were selected into this study. These were the materials I used. Here I would declare there were no conflicts of interest. Essentially, I used calcium morginate dressing and povidone iodine too. The other materials were also used. These are not the conventional materials that we use for such procedures, hence they are itemized. Anesthesia for this patient was either general or regional, depending on where the wound was. Preoperative antibiotic was same for all patients. Donor site wounds was the anterior thigh, and we had the limitations in order to remove confounders. The dressing, primary dressings following the donor site wound created, which we used the Humvee knife, that had similar set points for every patient. The dressing that was used was either calcium morginate or povidone iodine, depending on the group that the patient has been selected into. The post-operative medications were same for all patients. Now come to the outcome measures that we were trying to find out. Pain. We assessed pain using the numeric rating scale that classified pain into 4 groups: no pain, mild, moderate, or severe. Infection was actually identified using some opting criteria, while revitalization was set at 95% wound healing. That I did by using the Digimiger software that will help us tell us the percentage healing for each wound. Categorical variables were analyzed using the chi-square and the Fisher test. To compare means and continuous variables, we used the t-test. Statistical significance was set at a p-value of less than 0.05. Now for my result, essentially the findings of importance came on day 3, day 5, and day 14, where it showed that there was a significant difference between the two groups in favor of calcium morginate. This was in tandem with studies that was done by Ranger et al. And Otwood, where calcium morginate was seen as a better dressing in the management of pain for these patients. However, this was at variance with people like Brommer and Disa, which found no difference in terms of their use. Now, when it came to incidence of infection, it was not statistically significant. There was only one patient in the calcium morginate group that had infection. When it came to revitalization of the patients that I used, 35 out of 36 actually had complete revitalization, which was also not significant. In conclusion, I came up with the fact that yes, calcium morginate has several benefits that has been identified in the literature. We here, if you put the rate of revitalization and infection into perspective, there was really no significant difference. But calcium morginate was a better dressing when it came to pain management. Now, my limitations were I lost 2 patients to follow up during the course of the study, and I also felt maybe the number of patients may not have been a reason why there may not have been no difference in other things I set out to achieve. Recommendation, I believe, more patients to be used for this study, probably a difference may be identified, and the revitalization rate of 95% should be extended to 100%, a difference will be identified. These are my recommendations. Thank you.
Thank you for your presentation. We'll take 2 questions from the audience, please. Any question for him from the audience? If there is none, we'll start from here. Why what you say was the reason for non-availability of calcium morginate use in Nigeria?
Okay.
And secondly, is there any difference between the cost of the two?
Okay. In terms of availability, sorry, sir.
No, go ahead. No, I just wanted to ask so that you answer together. Did you look at confounders? Did you look at the BMI of this child, whether they're diabetic, the size of the wound you are grafting, the recipient wound, and even the location of the body, the blood supply and other things? Because those are things that will affect on the pain, on the healing, on the epithelialization. So I'm sure
yes, so that was also my worry, because when you're doing conclusions like this, I expected to see your logistic regression table where you actually exclude potential confounding variables in your work. And then I wasn't clear about your study design and the sampling method that you used. And my last comments, what are the implications of these findings for practice? You know, as you're a surgeon.
Yes.
So what would you recommend to other surgeons and, you know, the manufacturing company here or the drug company here? What is your recommendation to policymakers really on this study? Because, you know, where things work, they actually depend on research to make informed decisions. You know, everyone is here. Policymakers may be here. So what is your take-home message and what are the implications of this work for policy, for practice? Thank you.
Thank you for the questions. Concerning the first question, in terms of cost, there is a slight difference in terms of cost. Calcium arginate is slightly more expensive, but in terms of availability, it's readily available. Then in terms of the confounders that you identified, yes, I paid attention to that particular fact. One of the inclusion criteria was the fact that the size of the wound was important. So the size of the wound was between 5 and 50 centimeter. Putting that into consideration, that the larger the wound size, the more pain receptors that are activated, the more pain the patient will have. So that was put into consideration. But yes, it was also analyzed because each of those patients had their wound size documented, and that was subjected to analysis if the wound size had an effect on the findings in the research. Then outside that, you also talk about confounders such as, I think the only confounder we took into consideration was the fact that, yes, size may be a major effect. We also put into consideration age. Age was a problem, and that's why you note that the inclusion criteria contained ages between 10 and 65. That's because ages less than 10, children will have issues actually having to document their pain properly. They use the facial scale, and this particular study was taking into consideration the numeric rating scale, which was better for adults. Then ages that was more than 65 were excluded because at that age, their skin laxity will also have an effect on the finding in the study. So that was the reason behind trying to put into consideration the confounder. That's for my sampling method. What we did was, for each of these patients, was a simple random sampling method, but I was using the app calculator net. The sample size was for 36 patients, and the app had a way of generating 2 groups for patients. So 2 groups were generated even before the patient presented. But as they present, they were given numbers in sequence that if each patient that is presenting this, you are number 1, you're number 2. But now, number 1 may belong to the calcium arginate group or the povidone iodine group. So depending on the group that the generator app has placed you in, that's the agent that will be used in order to rule out bias.
Thank you. Thank you very much.
Yeah, round of applause for him. That was contestant number 6. Contestant number 6. You know, you just have to love doctors. The way they make things that we think are very big sound so casual. You know, like you said, I lost 2 patients. We may need more patients. All right, we move on. Next, we have Dr. Kenechukwu Imefuna. I hope I got that. Imefuna. You're welcome, sir. Contestant number 7.
Good afternoon, all. My dissertation topic is the role of albumin in predicting morbidity and mortality in perforated peptic ulcer disease patients in FMC Asaba. And the justification for the topic is from the fact that perforated peptic ulcer disease is a common indication for emergency laparotomy in surgery, also in my center, just like it is in the rest of the world. And also the morbidity and mortality is very high. Mortality is as high as 20% and remained high in our center, despite the fact that our patients are younger and the risk scoring systems that are available for determining the possibility or probability of mortality is either cumbersome, not objective, or they are even too subjective to be used. And also, some researches outside Nigeria have shown that serum albumin is very sensitive in predicting mortality in peptic ulcer disease patients. Such surgeries were not readily available in Nigeria. And most of the studies that were done in Nigeria were prospective, and hence the research questions of finding out the state of serum albumin in patients with PPUD in FMC Asaba, and also to know whether they can predict morbidity and mortality in our patients. So I carried out a research over 9 months, a prospective surgery, in which case the specific objective were to determine the serum albumin level of patients with perforated peptic ulcer disease, and also to find out whether they can help in predicting morbidity and mortality. My inclusion criteria included all the consecutive patients that were operated for perforated peptic ulcer disease in FMC Asaba, while excluding patients that may have had pre-operative diagnosis but did not undergo surgery for any reasons. Also, other exclusion criteria includes presence of tumors and also in patients that refused consent. And 21 patients that were recruited, they were resuscitated and samples for serum albumin were collected before surgery, second day post-op, and also the 7th-day post-op. While as a way of control, the apparently normal patients were selected from hospital community and were matched with the perforated peptic ulcer disease patients. And their samples was only collected once. And all the samples were analyzed using a semi-automated analyzer in FMC Asaba. The same reagent was used for all, which is Randox albumin. The people that underwent surgery had the same surgery, which is modified Graham's, and post-op care was similar. The only addition depends on the complications seen in such patients. The data was analyzed using SPSS 25, and serum albumin was also classified into normal, severe hypoalbuminemia, moderate hypoalbuminemia, and mild hypoalbuminemia. Regression analysis was used to determine whether they can correlate, the level can correlate with morbidity and mortality. So in my analysis, the patients that are the normal patients and perforated peptic ulcer disease patients were matched, and the serum albumin level was significantly lower in patients with perforated peptic ulcer disease, that can be shown at the p-value, which is less than 0.05. In the regression analysis, it was noted that for morbidity, it was noted that serum albumin level, can predict morbidity from second day, on the second day and on the 7th day. However, for mortality, it could not predict mortality in patients with perforated peptic ulcer disease patients in FMC Asaba. So my findings show that my mortality rate was very high, even for Nigerian studies, probably because they were retrospective. But my study was prospective. And also, the serum albumin could not predict mortality as reported in other studies abroad. And this may be explained by the fact that our patients are younger. And also, the prediction of mobility has also been seen in some studies carried out in Japan. However, I also noted that our patients are also younger, while the Western world patients were older. However, our own mortality is even higher than their own mortality. The explanation can be because of. So my recommendation is that.
Thank you very much. Questions for him, please. Dr. Ademolu.
Yeah, thank you very much. Just to add to that, I'm surprised you got this number of perforated peptic ulcer in Asaba within this period. I can't remember 1 year, 1 year, 9 months. For 2 years in Kano, I can't remember them getting perforated ulcer up to 5. So what is because so anybody say 25 perforations in 9 months in one institution? I think it doesn't reflect what we are seeing in Nigeria. So this is your data where you are the same thing with the confounders you are talking about. You cannot because his question because the pre-morbid albumin level. You think so many factors. The socioeconomic status, income, social class, occupation, because so many things they will have come with like a low albumin, even be able to perforate to follow with what he said. Thank you very much.
Any questions from? Okay, you can answer your questions, please. Yeah.
And it was found that we found out that Asaba covers for agrarian community in Delta State, most of which they take a lot of NSAIDs. And also, I asked around in Benin, they also complain of the same thing. In fact, they noticed that they have a very high mortality that they usually manage them to assess whether they can even qualify for going to theater. So that's what justified my even moving forward to determine the actual morbidity and mortality in my center. And before I started the research, I carried out a retrospective assessment in my center, and we had 17 patients that underwent surgery for perforated peptic ulcer disease, not including the ones that died before the surgery. So the premium may actually be more than is being reported. So that prompted me to carry out the research. And before the 1 year that I needed to complete my sample set, I actually got 20, which is the minimum required for me to analyze, and I started the analysis. Thank you very much, sir. Then, other confounding factors like the age, comorbidities, these were all in the previous scoring systems, like the BOY score, the PULP score, even the ASA score that has been used in many centers. In my center, what we use to score our patients is actually the ASA score. However, ASA score is not specific for perforated peptic ulcer disease. And having noted what everybody did, most of the studies that they did outside Nigeria, in fact, they noted that albumin for perforated peptic ulcer disease is a single most sensitive test that is done in order to predict morbidity and mortality in such patients. So that's why I tried to calm down my study in using albumin. And also, somehow, albumin is able to it's also a measure of some of these comorbidities, and also the intensity of the peritonitis that occurs in people with maybe presenting with peritonitis. So I selected it because it is easy to do. Also, it's cheaper. It's less than 1,000 in my center. And due to the fact that our patients, we have a lot of patient load with very little personnel to actually attend to the number of cases that we have. So I decided to carry out research and see how it pans out in my center. Thank you, sir.
Thank you very much.
Thank you very much.
Okay, that was contestant number 7. For non-medics in the house, mortality means death. Relate that to what I said earlier. Can we have the next presentation? Dr. Josephine Isioma Onumaku. I hope I got that right. Welcome. A round of applause for her, please.
Number 8, I guess. Yes.
Good day. My dissertation was titled Iodine Nutritional Status and Goiter Prevalence in Children aged 2 to 14 years in Selected Upland and Riverine Communities in Rivers State, Nigeria, a comparative study. As a way of introduction, iodine is an essential micronutrient needed for the synthesis of thyroid hormones. These are the hormones that play a vital role in the body's metabolic processes and in the brain development and growth of the body. So, an iodine deficient state, therefore, would lead to the development of a spectrum of disorders arising from this thyroid hormone deficiency, and they've been termed iodine deficiency disorders, IDDs. Among these, goiter is the commonest presentation, and other presentations like cretinism in varying degrees of mental retardation have also been seen. These are some children with iodine deficiency disorders. Okay, sorry, it's not going forward. All right, to control and prevent IDDs, the World Health Organization and ICCIDD came up with the Universal Salt Iodization Policy, and then this was, and despite the implementation of this USI policy over almost 3 decades ago, cases of IDD have still been seen to persist in the world. Globally, about 241 million cases of IDD have been seen in children globally, while in Africa, about 134 million school-age children have been seen to have that. We've also had sporadic cases in Rivers State, Nigeria. On the other hand, after the introduction of USI, iodine excess has also been seen. And so the World Health Organization and ICIDD recommended that the iodine nutritional status of a population be monitored in school-age children at least once every 10 years. Nigeria, on the other hand, had our last national survey over 17 years ago, and Rivers State was not one of the states assessed during that survey. And so I aimed by my study to determine the iodine nutritional status of children aged 2 to 14 years in the selected upland and riverine communities in Rivers States, using their urinary iodine concentrations, and the prevalence of goiter in these children using both clinical examination and thyroid gland ultrasonography. My objectives were to determine and compare the urinary iodine concentrations of these children in the selected upland and riverine communities, to determine and compare the prevalence of goiter in these children, to determine the relationship between urinary iodine levels and goiter in these children, and then the factors associated with urinary iodine level and goiter in these children, with the hope that my study will help to reawaken a statewide and nationwide focus on the monitoring of iodine nutritional status. To do this, I carried out a cross-sectional comparative study and had 545 children recruited from both the upland and riverine communities using the multi-stage sampling after meeting my inclusion criteria. A pre-tested interviewer-administered questionnaire was employed to collect their socio-demographic and dietary data, emphasis on use of gadrogenous diets. The anthropometric parameters were also taken, thyroid gland sizes measured using the ultrasound sonography, urine samples were taken for urinary iodine assay. Data were analyzed using SPSS between 25, thyroid volumes were compared with WHO and a Nigerian reference. And then appropriate statistical analysis were done. Ethical approval was obtained before the study was carried out. And so, the results of this study then showed that there was a significant difference in the urinary iodine concentrations of children aged 2 to 14 years in the upland and riverine communities, with those in the riverine communities seen to have excess urinary iodine concentration when compared to those in the upland. And this also translated to an above adequate iodine nutritional status in the riverines compared to the upland. There was also seen to be a significant difference in the thyroid gland volumes between both regions, with those in the riverine having larger thyroid gland volumes, which translated to a higher prevalence of goiter of 22.5% in the riverines, while compared to the upland region. Urinary iodine levels were seen to be associated with goiter in children in both regions, where goiter was found to occur in children who had above adequate and excess urinary iodine levels. There were no cases of severe iodine deficiency seen in this study in both regions, but mild and moderate iodine deficiency was seen slightly more in the uplands, 4.5%, when compared to the riverine regions. No goiter was seen on physical examination, only by thyroid gland ultrasonography.
1 minute more.
In summary, there was an above adequate iodine nutritional status in the riverine regions, while it was adequate in the uplands, and there were differences in the goiter prevalence between both regions, with goiter seen to occur with excess iodine nutrition rather than deficiency as earlier expected. So it was my recommendation then that there be a statewide and even a nationwide reassessment of iodine nutritional status, with a possible review of the level of iodine in salt in River States, emphasis for those in the riverine areas, and the thyroid gland ultrasonography be used to detect the goiter prevalence when these studies are being done to allow for timely interventions. Thank you very much.
Jones? Okay. Anybody in the audience with a question? Okay.
Yeah, thank you for your study. You are a pediatrician, right?
Yes, sir, I am.
Okay, I see that ultrasonography was part of the investigation.
Yes, sir.
Who did it?
I did that, sir. After
Do you have any
training
training in ultrasonography?
I was trained by the consultant and radiologist, who was also one of my supervisors. So I was trained over a period of some months, and then we had a Cohen's-Kappa score. We had to correlate to be sure that there was an inter-rater scoring of above 0.8. At that point, I could be allowed to go ahead and do, meaning that on comparison of my own findings and his own findings on the same patients, or if we repeated it, we would there'll be almost an 80% chance that we would get similar values. So it's until we got to that Cohen-Kappa's score of 0.8 and above, then I was allowed to go ahead with the study.
Okay, well, that's one of the problems I had with your study. The other one is this. I would have loved it if you compare your study and also choose a location that is known to be a goiter endemic area. There are areas like that.
Yes,
probably
sir.
for some capital reason you did not, but I would have loved if that was done.
Yes, sir. Thank you very much, sir.
Sorry, why did you choose 2 to 14? Because if you why do you stop at 14? What age group are you defining? Is that the definition of a child in your list? And why 2? Why not 3? Why not 5?
Okay. The WHO had actually recommended school-age children. Usually they'll do between 6 to 12. But seeing the latest trend we had, that even children as low as 2-year-old usually have already been introduced into school. And I wanted to get the whole range of children, of school-age children. So I had to go down to children 2 years old, and they were school-age children already in school, up till 14 years. They were still adolescents up to that 14 years. I didn't want to go beyond 14 years, beyond the adolescent, because then I would also be entering into the females of childbearing age. But I wanted it to just be up to the children within that age.
So it was your own, not based on standard categorization, it's your own thought.
Yes, sir. There's no standard categorization for that. Different studies have done different age ranges on this iodine nutritional status.
Thank you.
So I would just like to know how you recruited you said it was a multi-stage.
Yes, sir.
So when you got to how many stages?
There were 4 stages.
Okay, so I'm interested in how you recruited the participants.
Okay, so it was a community-based
study.
Yes, study.
Excellent.
So after community entry with the indigents, because of language barrier, of course, I got the social mobilization officer from each of the local government areas to go along with me. So on doing that, we just did a random sampling. After getting to the community center, as determined by them, we just did a spinning on randomly selecting the areas in which to go, and then we did house to house, selecting 1 child per household until we get to the end of the direction, houses in that direction, and then we'll come back again to the center and do a random spinning of another direction to go. So we continued that in each of the communities that had been pre-selected until we got the number of participants we needed in that community.
What is that? That's what I'm interested in. So you did a cluster in your last stage?
Yes, we did a cluster in the last
Because when you go from house to house like that, you're making sure that you capture everyone that is eligible.
Yes, ma'am.
Okay, thank you.
Thank you very much, ma'am.
Thank you very much.
Thank you very much.
So after this next presentation,
Yeah,
we'll rest for 10 minutes and come back.
5 minutes.
5 minutes? Okay. And then we'll come back, yeah?
All right. So we'll take the last presentation for this phase of the competition. That's last of the first set of presentations. This will be taken by Dr. Ifeanyi Ichezona Nwanfo. Is contestant number 9.
Good afternoon, sir. Good afternoon, all. I'm presenting on pure tone hearing threshold among TB patients receiving anti-TB drug in youth. These are my outline, my approval letter, no conflict of interest. That's it. By way of introduction, tuberculosis is a contagious and also a fatal infectious disease caused by Mycobacterium tuberculosis. It causes hearing loss by selective destruction of hair cells and their degenerative changes within the cochlea. For justification, there's need to know the hearing threshold among TB patients in our youth. And then several studies have looked into the use of injectable anti-TB. However, very few in my environment looked into the use of oral anti-TB drugs. In 2016 May, WHO introduced an all-oral shorter treatment regimen for multi-drug-resistant TB patients. This study actually notes to know if there is effect of this new drug on the hearing of the patient with anti-TB drugs. And lastly, the finding will add to the body of existing knowledge in improving quality of life for the patient and also to impact on the treatment guidelines. Thus, the aim is to ascertain, to determine the prevalence of hearing loss before commencement of anti-TB drugs, the incidence of hearing loss after commencement of anti-TB drugs, the types and severity of this of hearing loss, and then if there's any association between pure tone hearing threshold and anti-TB medication. It is a prospective cohort study done at Ikeja Teaching Hospital. Those not noted to have TB infection, similarly healthy age, matched with age and sex participants that signed consent were noted for by control. For eligibility, those diagnosed having TB with either gene expert or ALB that with or without commencing anti-TB drugs within the age of 18 to 60 were under my inclusion criteria. For exclusion, those non-diabetics, ROBD positive, hypertensive, those on ototoxic medications other than anti-TB, and those with preceding hearing loss were excluded from this study. A minimum sample size used was 75, a group, using a Fisher's formula, with attrition rate of 10% and an estimated prevalence rate of 22.9. A combination, an interview administered questionnaire was used to obtain my data, and a gene expert, AFB, otoscopy, tuning fork, and pure tone odometry were actually done. The pure tone odometry was carried out to the patient and also control at the baseline, that is the time of enrollment, following which pure tone odometry was repeated at the 60 and the 90 of commencement of TB drugs. The data were collected and analyzed using Starter version 16. The descriptive characteristics of the patients were summarized in tables, figures, frequency, proportion, means, and standard deviation. Chi-square for categorical, and t-test and ANOVA for continuous variable. So p-value less than 0.05, we are considered statistically significant. Now for discussion, this was my flow chart. We noted we assessed 240 participants, that for which we excluded 44, and 196 we are recruited for this study. 98 for case and 98 for control. None were lost to follow-up. The discussion was in accordance with the objective of the study. And the preceding findings, principal findings here,
1 minute more,
include zero prevalence and 4.1% incidence rates, which was in keeping with findings by Koza Shingazi, who noted there, who has 6.7. But contrary to the finding by Ibekwe, Sogabe, Sagwa, their reason was that they used injectable anti-TB drugs, and also there is lack of follow-up in their studies, and then inclusion of TB, HIV affected patients were their reasons. 2, we noted a bilateral sensory hearing loss at the 3rd visit, which is the 90, and which is considered with the finding by Sagwa, Timara, and Dosus and Sharma. Thirdly, we noted 3 moderate hearing loss and 1 mild sensory hearing loss. The reason could have been due to the fact of multi-systemic effect of anti-TB, and also some of those patients could have been with other ototoxic medications. Lastly, there was no association between use of anti-TB drugs and hearing loss.
Thank you.
Okay. So my recommendation, not from the studies.
Time up.
Thank you. Thank you very much.
Thank you very much. A round of applause.
Can we have one or two questions for him from the audience, please? Any question for him, please? Yes, please. Okay.
Yeah. Good afternoon, everyone. Thank you very much for your presentation. Very wonderful topic. I just need some clarification. In terms of the hearing loss, which age category has the highest? You know, I don't know how you categorize. Probably you use 18 to 25 or something. Maybe 3 different groups. There will be a group that probably has the highest. That's one. Then secondly, what sampling method did you use for the control group? Thank you very much.
Thank you.
Yeah. Thank you very much. You know, the amino glycosides, particularly, I've known for hearing loss, and that's why he said those that used parenteral before. Now, of the anti-TB drugs, only the ethambutol that causes some tinnitus. So they may not have pure tone deafness, but did you assess for that? Because that's the side effect they have. They don't have to have they have tinnitus, which is not analyzed in your, this is why. Thank you.
Just to clarify, was it a multi-center study or just on one site? And then 2, your selection of controls. I always have a problem when you just go and select healthy subjects from, wherever. Your controls must be as similar as possible to your cases, okay? Except that they don't have the disease of interest. So you must ensure that similarity, otherwise you're picking a wrong control group. And then this issue of prospective cohort study, those terminologies have long been, thrown out. So if you're doing a cohort study, just tell us you're doing a cohort, okay? Thank you.
Thank you. The age group most prevalent in this study was between 29 to 50. These are the age mostly affected. Now, coming to the control, how I selected my control. The treatment group were first done, and then following which the control group will follow the same sampling technique, which is the convenience sampling technique that was used. It's a non-parametric analysis. And if you look, it's one of my limitations that a randomized control trial could be recommended for future study. So now going to how your question based on the control, sorry? Yes, matching, because of time, I wasn't able to go into the detail. Matching of the control and the treatment group. Yeah, it's a hospital-based study. And so the control stems from, 1, the hospital staff, students within the hospital, and also the patient relatives within the hospital premises. And sir? No, that's my prevalence. My prevalence was 0, no TB for the control. And then my incidence was 4.1%. Thank you.
Thank you very much. So we'll have a brief break, yeah?
Yeah, thank you. We'll break for 5 minutes.
5 minutes, and then we'll come back.
We will convene for the next 7 presentations. Please, a round of applause for all our presenters.
need to wake up as early as 5 a.m. to start my day in preparedness for the marathon lectures that sometimes last till 6 p.m. It takes a huge toll on my body. I then have to mix it up to study. And honestly, if it wasn't for Ikeja that is always with me, having all these constant headaches caused by all of this wahala, I don't know how I'll be able to cope honestly. My name is Chisu, and this is my Ibuka story.
Driving over in the city of Lagos is an extreme sport. There are days where I have to drive 20 out of 24 hours. And this takes a huge toll on the body. You know, it's easy. I also do this much to ensure that I am able to survive in this city and provide for my family. I often take my rest, and Ibuka is always with me when the inevitable body pain strikes. My name is Dari, and this is my Ibuka story.
One night is very hard for me. Every day I need so much for my shop to buy anything you want. My Ibuka always there with me. One day Ibuka na ina the koyoshi. It helps me when you train me. My name is Hassan. Now my Ibuka story be this.
Good morning, my people. It's another day to get out there. Go after your dreams. Head out for sustenance. Work for the future. Life can be good, bad, or painful. For those painful periods, you always have a partner to count on. Ibuka is your go-to partner that keeps pain away. Ibuka is always with you, giving you the desired relief from pain. Ibuka capsule, always with you to beat pain. Marketed by Shalina Healthcare Limited.
My voice is my identity. Don't lose your voice when you need it most.
Don't lose your voice when you need it most. Shaltu lozenges.
How do you respond to a burning sensation in the chest that usually occurs after eating your favorite meal?
I respond fast with Polygel. Well, I'm not selfish. I pass it on.
I experience heartburn, and I respond fast with Polygel. I am not selfish, so I pass it on.
I often experience indigestion with growling stomach, and I respond fast with Polygel. I am not selfish either, so I pass it on.
I experience heartburn because my baby bump gets bigger, pushing stomach acid upwards, but I respond fast with Polygel.
When heartburn robs you of the comfort of eating your favorite meal, respond fast with Polygel, which has the highest acid neutralizing capacity. Polygel antacid, soothing relief from heartburn.
Hey, action no day today. Now malaria day. Sister, this malaria I won't kill action for my body. I beg just give me that anti-malaria drug what I take the last time.
Oh, you mean
Charlatan?
There you go.
Now correct anti-malaria drug with this. In fact, Charlatan, now the real deal.
No let malaria comot action for your body, oh. NECA Charlatan, a brand of anti-malaria that contains artemether and lumefantrine. Charlatan, na medicine from Shalina Healthcare Nigeria. Charlatan, them get them for every age group them. Make you remember to always take Charlatan with food. If symptoms no change after 3 days, go see your doctor.
Hold on. Good. See your chicken, we just say the wine. But you say that day can't now. You shock you, Abby.
The world of boxing is in shock.
The highly acclaimed champion, Mr. Three Blows, has fallen ill. Mr. Three Blows is experiencing malaria symptoms. Will he be able to deliver the knockout performance we've come to expect? Will he be forced to withdraw?
Mr. Three Blows, you know how much I don't bet for it? I got stand up with you. Oh, when I go DJ. Oh, yeah, Kate. Make you use and sharp. Shalatem, he too sure. Mr. Three Blows.
Mr. Three Blows and his fans celebrate victory thanks to Shalatem anti-malaria drug.
Shalatem knocks out malaria in 3 days.
Neck pain and being a mechanic is like 5 and 6 because the work requires a lot of energy. I have to always be ready for any problems that a customer can bring because my family has to feed, from engine to exhaust, tire to battery. It causes neck pain for me well. That's now why my Ibuka, they always stay with me. In fact, it's in my pocket right now. My name is Natunde and this is my Ibuka story.
I think I was probably about 15 years old when I saw this friend of ours just punching and kicking, and now in the uniform. Okay, wow, that guy does karate. You know, so we approached him, and it became our first.
Which will bring us to the end of the first round of this competition. Thereafter, we'll move on to rapid fire, where we'll be seeing the Usain Bolts and the, what's a Nigerian athlete? Tobi Amosuns among the consultants. All right, before we get into the next set of presentations, I'll just like to call on Famayo to recognize some of the very important guests that we have in the house.
Thank you. We have very important guests, just like Riley said, in the healthcare profession in the country. First, please, I want to recognize Dr. Ademolu Adegbenga. He's a consultant endocrinologist. He is representing the CMD of Lagos State University Hospital, Lasut, Ikeja. That is Professor Adetokunbo Fabamwo. And also the head of clinical services, Professor Adebowale Adekoya. You're welcome, Dr. Ademolu. Thank you, sir. You're welcome. Next is Dr. Adedeji A.O., the head of medical services, WAEC Clinic. You're welcome, sir. Then, Dr. Atebaka OT is the chairman, MD Khan, National Orthopedic Hospital, Igbobi. You're welcome, sir. Thank you, sir. Right. Dr. Sixtus Ozumba is the chairman, SOFPON, Lagos State Chapter, and currently the head of Family Medicine, General Hospital, Lagos. You're welcome, sir, as always. Dr. Ozeigbe Ogide is a consultant family medicine in LUT, and currently the secretary of SOFPON, Lagos Chapter. You're welcome, sir. Right. Farm Anibaba AL is the HOD pharmacy, and currently is representing the medical director, General Hospital Onikon, that's Dr. Adebajo. You're welcome, sir. Dr. Onolapo Nuruddin is the deputy MD and currently representing the consultant, Ops and Gyne, representing the medical director, General Hospital Ikorodu, that's Dr. Taiwo Hassan. You're welcome, sir. Thank you, sir. Dr. Folashade Daniel, consultant cardiologist, Lasut. You're welcome, ma'am. Thank you. Thank you for coming. Right. Dr. Akimboade Francis, consultants, Ops and Gyne, Lagos Island Maternity Hospital. You're welcome, sir. Dr. Akimboade. Right. Dr. Muftau S. is the HOD, GOPD, General Hospital Isolo. You're welcome, sir. We also have with us, Dr. Ajayi O.A., Consultant Internal Medicine, and also Head Research and Training, representing the CMD, Federal Medical Center, Ibutemeta, Dr. Daramola Dada. You're welcome, sir. Dr. Oloyede F.A. is a consultant, Obs and Gyn with Orile Agege General Hospital. He's also here with us. You're welcome, sir. So in the course of the presentations, in the course of the program, we will recognize others, important dignitaries. Thank you very much.
All right, thank you, Famayo. So we've had the first 8 of 15 presentations. We're going to continue with the 9th presentation today. And the next presenter will be Dr. Lawani Ufadime. I hope I got that right. A round of applause for her, please. Number 10, yes.
Good afternoon, everyone. I'll be presenting efficacy of preemptive analgesia on post-operative pain and quality of life among patients undergoing mandibular third molar surgery. Now, mandibular third molar surgeries are common surgical procedures that take place in the dental clinic and is oftentimes associated with some post-operative complications like pain, swelling, trismus. But in particular, post-operative pain increases the suffering and anxiety of the patient, and it can demoralize both the patient and even the surgeon. It's also a key symptom that has been associated with possible impairment of the oral health-related quality of life of the patients. And then preemptive analgesia is defined as a treatment that is initiated before surgery in order to prevent establishment of central sensitization. So it is thought that when an analgesic intervention is initiated before the surgical procedure, both intraoperative and postoperative nociception can be mitigated to the central nervous system. And this will provide superior benefits in comparison to this same analgesia if given postoperatively. And then we know that the management of pain is still quite far from being satisfactory, with many patients being at risk of developing chronic pain if they are not well managed. And chronic pain is a disabling condition that can affect every aspect of the patient's life, and it can contribute to a loss of physical, emotional function, and then inability to function in the workplace, social activities. And the quality of life of the patient can also be negatively impacted upon. And then there still exists controversy as regards the efficacy of preemptive analgesia. Therefore, the objective of this study was to determine the efficacy of preemptive plus postoperative analgesia versus postoperative analgesia alone on postoperative pain. And then 2, to determine the efficacy of preemptive plus postoperative analgesia versus postoperative analgesia alone on the quality of life of the patient. Now, the study was a prospective randomized study that took place in the University of Benin Teaching Hospital. We had, the study population was adult patients that presented for extraction of their mandibular third molars, and we had a total sample size of 66 participants that were randomly, with a simple random sampling, they were divided into 2 groups. Now, the group 1 patients, they were given tabs diclofenac potassium, 50 milligrams preemptively, that's 30 minutes before the surgery, and then 50 milligrams post-operatively, then 12 hourly for 5 days. While the group 2 patients, which was our control group, they were given tabs diclofenac potassium, 50 milligrams post-operatively, and then 12 hourly for 5 days. The tools for data collection, for the assessment of pain, we use the visual analog scale, while for the assessment of the oral health related quality of life of the patient, we use the modified oral health impact profile 14 questionnaire, that is the OHIP 14 questionnaire. And then the data was analyzed, and then from the results, we found out that we had more females than males in a ratio of 1.4:1. And then we had a median age of 24 years and then a median surgical time of 21 minutes. Now, from the results also showed that for the pain assessment, the patients that had preemptive plus post-operative analgesia, they had lowered pain scores compared to those that had post-operative analgesia alone. And at all the time points where we measured, it was statistically significant. And then also, for the oral health-related quality of life of the patient, we found out that all the patients that had preemptive plus post-operative analgesia, they had lower OHIP 14 scores compared to those that had post-operative analgesia alone. And on day 1 and day 3, this difference was statistically significant. But on day 7, the observed difference was not statistically significant. So with the conclusion drawn from this study, was that preemptive plus post-operative analgesia was significantly more effective in reducing post-operative pain compared to post-operative analgesia alone. And then patients who received preemptive plus post-operative analgesia, they had significantly better quality of life compared to those that had post-operative analgesia alone. The limitation was that it was a single center-based study, so a multi-center design will help to further generalize findings. So the study is that the use of preemptive plus post-operative analgesia should be adopted by family dentists, oral and maxillofacial surgeons for effective pain control and better quality of life among patients that undergo mandibular third molar surgery. These are my references. Thank you for listening.
Thank you for the presentation. Do we have 2 questions from the audience, please? If you have any questions from the audience, 2, just take 2. Okay, so how did you choose recruit the participants in this group? How did you recruit them?
Okay,
that's number 1. Number 2, what is really new? What is new in what you have presented? What is new about it? Just take the question.
Exactly. You have 2 groups. One group, you give 2 apples. The other one, you give 1 apple. What do you expect? This one, you give pre-operative analgesia. It's already having analgesia, and then post-op, you give analgesia. It's clear from the beginning what the result will be. So you can't give pre and post one group and one only post group coming with their pain from the extraction. So the result will be clear ab initio. That's my worry with this study. And it didn't tell us about I'm sure you infiltrated the molar that you are removing, isn't it?
Sorry, sir?
You infiltrated for anesthesia, isn't it?
Yes, sir.
So did you correct or match for the amount of infiltration? Because the quantity of this you are going to use to infiltrate for each group. Otherwise, you will have another one that you load 5 mil, another one 2 mils, and then you will not make any reference. Thank you.
Yeah.
Let me just take so that you answer all the questions at once. So my first question is, in selecting the pain relief or the analgesic, did you work with an anesthetist to select the appropriate pain relief medicine for the patients? And then what was your study design really? So 2 questions. What was your study design? Because from what you presented clearly, I would say, okay, let me allow you to talk, then you tell me what study design you used.
Okay. First of all, the conventional practice is that we give conventionally, post-operatively, these drugs. Now, studies have been done. Studies are being done that to be able to know whether if we give a preemptive analgesic agent, will it give us a better result? Now, some other people have done it and it gave better result, and then some others have done it and it did not. There was no significant difference. So the idea was to see it to help to. It's still a controversy in the field. So the idea was to see if this study, which line this study would toe, will it support preemptive analgesia so that we could make the patient's quality of life better or not. And then during this study, the quality of life has not really been examined with for third molar surgeries using preemptive analgesia. So we added the oral health related quality of life also. And then for the study design for this thing, it was a prospective randomized controlled double-blinded study. And then we used consecutive patients that came in for the surgery. Yes, sir.
So for the purpose of field, because we may end up publishing this work.
Yes, sir.
If in terms of ethical and consent taking,
yes, sir,
you see a young anxious the man who you want to remove his teeth. He said, look, I have two groups. He has already established so that if you have this drug before and after, we will see whether it will, and we'll give you only after, we'll deny you the before. How are you able to convince them to enter the group with only one dose?
And then for me, I would say it's a quasi-experiment because there was no randomization, if you ask me. Randomization should ensure that the confounders are spread across the two groups, and it's done in a manner that, the participants don't even know where they're going to. Okay, so you call it a quasi-experiment. Quasi meaning that one of the core components of an experiment is missing, which is randomization here. Okay, so I'm just correcting you. Consecutive again, is another, just bias the study a bit. Thank you.
Well, thank you very much. Please sit down.
Thank you, sir.
Thank you. Okay. I have a story about a dentist, but I won't tell you now because we are conscious of time. I'll tell you later. We're moving on to the next presentation.
Contestant number what? Okay. Taye.
So this is, the presentation is by Dr. Taye Kelani, is contestant number 11.
Good morning, everybody. I'll be presenting the topic, prevalence and characterization of carbapenems producing. Okay. I'll be presenting the topic, the prevalence and characterization of carbapenems producing gram-negative bacteria among patients with healthcare-associated infections in government hospitals in Kano. Carbapenems are antibiotics of last resort. They are used to treat very difficult infections. Then carbapenems are enzymes that gram-negative bacteria produces that destroys carbapenem antibiotics. So people with infection with gram-negative bacteria elaborating the enzymes have high probability of dying from this infection. We can see the burden of antimicrobial resistance. Even in 2019 alone, the WHO added antimicrobial resistance as one of the top 10 killer issues in the world. Then, but studies were done previously, but most of the studies were restricted to the ICU, thinking that these carbapenems enzymes, bacteria, are restricted to ICU. Then this study is meant to determine if this bacteria has actually escaped to the outside world. So the aims of the study is to determine the prevalence of carbapenems enzyme production among patients with healthcare-associated infection in government hospital in Kano, to determine the antimicrobial susceptibility pattern of this carbapenems producing bacteria, also to determine the genes that are responsible for carbapenem enzyme production in Kano. This is very important because the genes would determine the antibiotic that you use to treat the patient. Then to determine the risk factors that are associated with carbapenems production among patients with this disease. The study is a descriptive questionnaire study. About 200 study participants were recruited from 2 government hospitals in Kano using stratified random probability sampling technique. We actually proportionate the sample collection based on the size, the bed size of each hospital to now get the study. Now, the inclusion criteria, they are consenting patient, the inpatient that is admitted into wards with healthcare-associated infection, and we exclude patients who are unconscious. Then we got our sample of 200 by using the prevalence by Oduyebo et al. He got a prevalence of 12.4, then we use it to calculate the size to get our 200. So consent was received, and we analyzed the sample, and we set our level of significance at 0.05. Now we got ethical clearance from the Kano State Ministry, and we observed biosafety. So this is the analytical process. We collected sample, then we perform AST on the sample, then we now screen the organism to determine if they have this enzyme. Then we progress to do a polymerase chain reaction to determine the presence of the enzyme. Then the study now showed that carbapenemase producing bacteria are actually present in Kano, about 8%. The study also noted multiple carriage of different genes of carbapenemase among patients in Kano. This is, to the best of our knowledge, this is the first discovery in northern Nigeria, and we have not seen any study that got this. Also, the study also noted that New Delhi metallo-beta-lactamase has replaced Verona integrum beta-lactamase as predominant carbapenemase genes in hospitals in Kano. This has a very serious implication because people who have New Delhi metallo-beta-lactamase producing bacteria, they are likely to die from this infection because no antibiotics yet to treat them. So we can see the risk factor we got. Then this is the polymerase chain reaction that the polymerase. So there is a micrograph here. So the micrograph is not showing. I don't know. Though there is we did a multiplex PCR, and the multiplex PCR determines we got a lot of genes actually. So the limitation is that this study was carried out in large government hospitals in Kano. So we need a more study in lower government hospitals, in lower hospitals, to determine the prevalence. And we expect that it might be higher because in these large hospitals, IPC procedures are well known. So these are our conclusions. And what are the recommendations? There is need for improved implementation of infection control and antibiotic stewardship practices.
Thank you for your time.
Thank you for the presentation. Can we have questions for him? Dr. Ademolu, please.
Thank you for your presentation. Now, during your methodology, when you got to the process of polymerase chain reaction, in the 200 cases, were there challenges with polymerase chain reaction? If yes, what are the challenges? If no, what are the usual challenges that PCR usually pose to researchers?
Well, let's not go to the theoretical part of what are the usual. Just tell us your challenges. Eh?
Yeah.
The second question from the audience, please. Yes.
Thank you very much for the presentation. I just need some clarification. While recruiting your patients, were there consideration on the severity of the illness of the patient? Also, did you consider the number of days on admission? Possibly patient has been on admission, has been on antibiotics and all that. Do you consider that? Then, I don't know, just tell us some of the co-founders that you experienced. Thank you.
Yeah, 1 minute. Yeah, what are these healthcare associated infections? You know, what are the details? Where did you get the samples? The catheters, the NG tube, you know, whatever, wherever. But really, apart from that, I must comment your presentation because of antibiotics problem that we're going to have.
You take all the questions. My worry is that you took 2 hospitals, isn't it?
Yes.
And initially in your preamble, you said because initially we thought it's ICU-based problem, and now it's moving out of the ICU. Yeah. But when you proportionate the samples that you went to the 2 hospitals, as somebody's asking where you are getting the samples from, where were you picking these proportionate patients in those? Did you exclude the ICU? Because I know Nasarawa doesn't have ICU. So, or you just make of what ICU and the one in the surgical ward, or because that's exactly what the confounders are talking about.
So
do you have any question? Huh?
Okay, so the first question is about the how do we recruit the patient? Okay, we recruited the patient. I mean, okay, the healthcare-associated infection. They are the infection that patient got after admission, 48 hours after admission. They did not have the infection ab initio, and the infection was not incubating. That is healthcare-associated infection. So we use the 48 hours. Those patients that present with healthcare-associated infection 48 hours after admission. They are the people. Now, for the level of, we now take prolonged antibiotics use of more than 7 days is termed prolonged. So patients who are on antibiotics for several days, more than 7 days, we had them. as a risk factor. Then, for the study, in how do we include ICU patient, or we do not include ICU patient? The patient, we collected sample from any patient with healthcare-associated infection hospitalized in these two hospitals. We base our sample size using the bed size. Kano is 750 bed size. The second hospital, the specialist hospital in Nasarawa was 350 bed size. So we calculated it and we divided the sample based on the bed size. And we do not restrict we do not restrict ICU or not ICU. We collected for every patient. And also the question about, did we consider the severity of patient condition? We do not, this bacteria does not look at severity of disease. You may be having the infection and you may seem normal, but between just 7 hours, the person will go into coma. So we take from patients that are hospitalized, presenting with symptoms. Now, which sample did we take? We take any sample. What healthcare? UTI, we took urine. Pneumonia, we took sputum. Meningitis, we took CSF. We took all samples, because if we were to restrict sample, we miss some patients. That was why we included any sample. Once you are hospitalized in those hospitals and you present with healthcare-associated infection, you are recruited.
Thank you very much. You may please sit down.
All right, on to our next presentation. Dr. Kilani doesn't want to leave the stage. Yeah? Okay, our next presentation is by Dr. Samuel Akpan, Contestant 13. A round of applause for him, please. Thank you, sir. This is forward. Good afternoon, everybody. Panel of judges. My dissertation title is A Diagnostic Accuracy Study Comparing Fine Needle Aspiration Cytology with Histopathology of Breast Lumps in a Tertiary Hospital in Calabar, Cross River State. We'll use the following outlines. Palpable breast lumps are usually of great concern to patients. In fact, globally, the statistics obtained show that over 1 million women have breast cancers. And the number trickles down to Africa as well as Nigeria from different studies that were carried out in the country. It has a psychological, social, and financial impact on the patient as well as the family, as we can see from the picture displayed. Determining if the breast lump is benign or malignant is very important to the surgeon because it helps him to plan treatment. The diagnosis of breast lump involves clinical, imaging, as well as cytological and histological evaluation. We have 2 forms of obtaining specimen for breast lumps. We could use a core biopsy, or they can be surgically excised. We could also use a fine needle aspiration cytology. One thing that stands out is that the core biopsy takes a bit of a longer time, usually about 2 weeks turnaround time, to obtain it, and undergoes more standard diagnosis like histology and immunohistochemistry. Fine needle aspiration, on the other hand, takes a shorter turnaround time and can be done by the bedside or even side labs within the clinic. Malignant lumps can progress rapidly to causing significant morbidity and mortality as shown in the diagram. Early detection can be achieved using FNEC, and FNEC technique has been found to be simple, reliable, less invasive, and economical, with few complications. Relating to the diagnostic accuracy of FNEC to that of histopathology scores has significantly improved and encouraged the use of FNEC in the early diagnosis of palpable malignant breast lumps, and treating this with possibility of cure. We have the NHS guidelines, that is National Health Service guidelines, for cytology, which shows the C1 to C5 grading, as well as the Scalp-Richardson histopathologic tissue grading. The SBR grading is used for malignant histology.
And then we compare that with the C1 to C5. Patients with breast lumps, usually mainly females, present in the surgical outpatients of our hospitals, and they're usually from resource-poor settings. Quite a number of them present late due to self-denial, lack of awareness, superstitious beliefs, and even financial challenges. And of course, the turnaround time, for waiting for histology, delays in making quick diagnosis. Thus, the need for FNEC, which can be obtained within 48 to 72 hours. Some of these patients prefer to expend their lean resources on ineffective complementary and alternative treatment. All this further contribute to delays. This study is justified by the fact that though many studies have been carried out on diagnostic accuracy of MNEC, but none really emphasize on the cytology grades, comparing it to the histopathologic SBR scores and its role in early diagnosis. The objective was to evaluate diagnostic accuracy of FNEC of breast lumps and its correlation with histopathologic diagnosis. Specifically, we were to assess the sensitivity, specificity, positive predictive value, and negative predictive values of using cytology in the Institute of Calabar. It was also to compare the fine needle cytology nuclear grades of malignant breast lumps with histopathology SBR scores. These were the hypotheses that were used in the study. The study design was a descriptive cross-sectional study with a population of, over a 12-month period, recruiting females in the clinic who had palpable breast lumps at the University of Calabar Teaching Hospital. The inclusion criteria included all those patients that gave consent and with breast lumps greater than 1 centimeter in diameter, age between 12 and 70, all patients. The exclusion criteria included all those with breast lumps less than 1 cm or ulcerated, recurrent, or inflammatory breast disease. So sample size was determined using the Tauriamani formula for descriptive cross-sectional study with categorical outcome. A total of 71 females were used and obtained 75 breast samples result. Data was collected, clinically and evaluated, and each of them were, cytologies were taken and each specimen was subjected to histology. A structured proof was used to obtain data, and analysis was done with the SPSS statistics version 24. A p-value of 0.05 was considered significant. Informed consent was obtained. Ethical approval was obtained with limitations. The limitations included mainly experience and skill of the principal investigator performing the procedure, as well as the training experience of the interpreting pathologist. Also, financial resources was a major limiting factor. These were the results. You can see that data obtained revealed a mean patient age of 32.94 years, and most of these patients were within the age group of 21 to 30. A total of 71 women with 75 breast lumps.
Thank you for your time.
Thank you for your time. Question for him, please. Any question for him from the audience? Okay, maybe we should start with the question. Professor Soman.
You don't have?
I'll ask my question.
Okay, all right.
It's a very sensitive topic.
So why did you exclude less than 1 centimeter? You may have your reason based on science, and then the sizes, we didn't get to see all your results. Because if the tumor is already 5-10 centimeters, and so the size, we didn't see your analysis vis-a-vis the size. So why did you exclude less than 1 centimeter? And did you compare this sensitivity and the specificity of all the diagnostic accuracy with the sizes? Because we didn't get to see, we didn't get to present everything. Thank you.
So the topic FNAC workout in breast cancer has been overflogged. So I'm just wondering, what do you think is new in this your study? That's one. Number two, how will you then be able to make a diagnosis of ductal or lobular carcinoma in situ versus invasive cancer with your FNAC? Because that is important in this situation.
Thank you, sir. For the size, less than 1 cm was found from different studies to carry high error rate, so it wasn't included in these studies. Also, what was the other question? The reason why this study was carried out was because we found out that fine needle aspiration cytology was correlated with, that is the C4 and C5, correlated with the SBR1, 2, and 3, which were histologic results. Now, with the ability, with this correlation and high sensitivity, it's now possible to detect breast cancer early. And most of these patients, though I didn't show it, presented at the secondary healthcare facilities most of the time before coming to tertiary facilities. So with this population going to secondary facilities, it's important to be able to pick up FNAC at this level and pick up malignant lumps through FNAC at this level and refer them appropriately to the teaching hospital for further care. The FNAC itself, at its primary stage, cannot be used to determine histology. However, what is known as cell agglutination test can enable clumps of cells to be formed into to give tissues that can be used to run histology. So the essence of this study was to help women to help detect breast malignancies early at secondary healthcare levels and refer them appropriately to tertiary hospitals.
Thank you very much.
Thank you, sir.
How was the size of the? How did you determine this 1 centimeter? Was it clinical, ultrasound, mammo, or this 1 centimeter? How did you rule out that this is 1 centimeter or more than 1 centimeter? Was it ultrasound or palpation?
No, they were palpable lumps, so we could measure with the tape across.
So how? Because that has ethical issue now. You say palpable, you are measuring with a tape, a lump within the breast. That's the radiologist maybe see a different size when you put your probe there. So and that's a very, very dangerous situation now. You tell a woman, you palpate, you put your tape, it's less than 1 centimeter. Meanwhile, it's actually 1.5 centimeter if you go to the radiologist. So I think this is something you should catch. Otherwise, it may even lead to litigation. He said, don't worry, it's less than 1 centimeter, you don't need FNAC, and come with invasive cancer, 6 month interval, and then there's a problem.
Thank you very much.
Thank you, sir.
All right, thank you very much. On to the next presentation. Dr. Aikome Usianele. Did I get that, sir? Is number 14. The previous presenter was number 13. Okay. All right. No, remember we're not calling in any particular order, although coincidentally it seemed at a point we're following sequentially. It was just a coincidence. All right, so thank you. Yes, sir.
Good afternoon, ladies and gentlemen. I'll be discussing my topic titled Accuracy of Preoperative Anthropometric Methods of Femoral nail length determination in femoral shaft fractures at the National Orthopedic Hospital, Igbobi. Femoral shaft fracture is one of the common presentations to an orthopedic hospital, and then the gold standard of management is locked intramedullary nailing. It's important to determine accurate length because studies have shown that it helps to maintain length and restore adequate stability. There are different methods in measuring femoral nail length. The ideal method is to measure it in the theater, intraoperatively. However, because of difficulty with all femoral nail sizes and fluoroscopy, which is a mandatory need for intraoperative measurement, anthropometric measurement is therefore advised, and that is taking measurement within defined landmarks in the body. And for the femur, the commonly defined landmarks are the tip of the greater trochanter to the lateral knee joint line, tip of the greater trochanter, which is the GT, to the superior pole of the patella, as measured on the lateral aspect of the thigh, and then tip of the olecranon to the tip of the little finger. So, based on the cost of fluoroscopy, unavailability of nail size and environment because of the financial implications, and the fact that intramedullary nailing has been shown to be an effective method, and then paucity of studies in the environment, my studies therefore sought to compare 3 different anthropometric methods with femoral nailing and to determine which is most accurate. The study design was a cross-sectional analytical study that was done in a period of 1 year. 64 patients were recruited in this study using the Tarayamani formula, and then the inclusion criteria were skeletally matured patients with femoral shaft fractures on unilateral femoral shaft fractures, with skeletal shaft fractures on unilateral femoral shaft fractures, with skeletal for intramedullary locked nailing. For the methodology, the proper anthropometric measurements were measured pre-operatively, having identified the landmarks as shown on the images, and 3 measurements were done to determine the mean. And intra-observer reliability was tested using the intraclass correlation coefficient. The intraoperative measurement was done by the guide wire technique under imaging. For the intra-observer reliability, it was observed that the measurement by 3 different observers had excellent reliability. And then for the mean values, it was observed that the distance between the GT and the superior pole of the patella, as well as the tip of the olecranon to the lip of 2 fingers, minus 3 centimeters, we had no significant difference from the intraoperative femoral nail length compared to the other 2 measurements. And when we went further to try and determine a margin of 0.5 centimeters from the intraoperative femoral nail length, we observed that about 66% of measurements were in the GT to the superior pole of patella were within that margin of 0.5 centimeters, while for the tip of olecranon, tip of little fingers, only about 7 were within that margin. And when 3 was subtracted, this actually tripled. So, in our discussion, the distance between the GT and superior pole of patella was noticed to underestimate the femoral nail length by 0.1 centimeters. This is and had the highest correlation. This is similar to findings by Premkumar et al. In India, and was known to have a 66% margin within 0.5 centimeters. Whereas the distance between the GT and the lateral knee joint line measurement overestimated the femoral nail length by 14 millimeters, which is higher than excessive increments in the femoral nail length. And this was also similar to findings by Premkumar et al. The correlation for the distance between the GT and lateral knee joint line was less than that of the GT to the superior pole of the patella. The distance between the tip of the olecranon and tip of little finger overestimated the femoral nail length by almost 3 times a successive increment in femoral nail length. And this was similar to finding by Premkumar et al., for which they then advised that 3 centimeters be subtracted from that measurement. And when we did that in our study, we noticed that about 31% of our population had a higher value within 0.5 centimeters of the measurement. And although the correlation was lesser than that of the GT to the superior pole of the patella, as well as the GT to the lateral knee joint line. So in conclusion, studies have noted that the 3 different anthropometric measurements correlate well with the intraoperative femoral nail length as measured by the 2-guide wire technique. However, the distance between the GT and the superior pole of patella had the strongest correlation and thus it was the most accurate. However, in settings where the greater trochanter cannot be palpated, such as a patient with obese patient or patient that have bilateral femoral shaft fracture, an alternative method that can be used is to use the distance between the tip of the olecranon and tip of the little finger. And this is very important in an environment whereby they don't have all available nail sizes in theater and they don't have fluoroscopy, because the fluoroscopy costs as well over 75 million naira. So our recommendations are that where available, the distance between the GT and superior pole of patella should be used for measurement femoral nail length. And where this is not available, the distance between the tip of the olecranon and tip of the little finger should be used, and 3 centimeters should be subtracted from this. Thank you.
Thank you for your presentation. Can we have 2 questions from the audience for him? So what is the formula for your K nail length? Do you have a formula? Did you arrive at a formula now?
Well,
have you done this study? Is there a formula, this plus this minus this equal to that?
I didn't put that here because of time.
Okay.
I did a variance analysis and I got formula for the 3 different measurements.
What is very important. So did you rule out anybody when you are doing this study?
Yes. Who? There are exclusion criteria. So any patient that had a preoperative deformity in the forearm was excluded. Patient with bilateral femoral shaft fractures was excluded. Patient with limb length discrepancies.
So any formal fracture or you excluded them, isn't it?
Son?
Anybody that has any manipulation of the femoral was excluded. All right.
Thank you.
So just to correct your study design, so you said you'd use the prospective analytical cross-sectional study. So I think what you use is a comparative cross-sectional analytical study. That's your design. Okay?
Thank you.
Thank you. And then I was expecting to hear, what was your test of significance for comparing the 3 methods?
I used this Peptic test to compare the means of. So I didn't compare the 3 methods. I compared the mean of the distance between the GT to superior pole of patella to the intraoperative femoral nail length. And then I compared the mean between the distance between the GT and lateral knee joint line to the intraoperative length. So at every point of my comparison was just 2 parameters. If it was more than that, I would have used them.
Why didn't you use median?
Pardon?
Why didn't you use median instead of mean?
It's a continuous variable. I needed to use mean to determine each of these variables.
So you mean you don't use median for continuous variable? Is that what you're saying?
No, sir. What I mean is, for the measurements I did, each of these patients had different measurements. I needed to take a central point that was most reflective of my measurement, and I used the mean and not the median.
Okay, maybe just to correct us. So when you use the median, that means your data is not normally distributed. Okay, so the median is a more appropriate tool for central tendency when data is not normally, or data is skewed. So your data was normally distributed, which was why you chose the mean. Okay?
Thank you.
Thank you very much.
Round of applause. Okay, we have 2 more presentations to go. Next presentation will be by Dr. Abdullahi Miriam. A round of applause.
That is contestant number
15.
Good morning, good evening, afternoon, respected audience. Permit me to stand on the existing protocols. Thank you for giving me the opportunity to share the findings of our work, stated the efficacy, safety, and patient satisfaction with transcleral diode laser cyclophotocoagulation in the treatment of glaucoma, a randomized controlled trial. These were my supervisors. Now imagine what any of us will feel when we close our eyes for a second. How do we appreciate this whole? That's the impact glaucoma has on our patients. Glaucoma is a cause of irreversible blindness, is the leading global cause of irreversible blindness, and accounts for the greatest proportion of blindness in Africa. Now Africa accounts for the greatest proportion of blindness globally. Even in Nigeria, the story is the same. The mainstay of glaucoma therapy currently is the medical, surgical, and laser therapy. However, transcleral diode laser cyclophotocoagulation is a form of laser therapy. That applies laser therapy to the sclera with the aim of bringing down the intraocular pressure. Now, there are certain peculiarities of glaucoma in the black population that poses significant challenge to its management. It runs an early and aggressive course. There's usually asymptomatic. There is poor awareness about the disease. Furthermore, poverty makes adherence and persistence of medications and follow-up visit to be dismal in this disease that requires lifelong therapy. Therefore, we need to find a treatment option that will provide a stable, long-term intraocular pressure control and that is affordable by the majority of the population. We therefore set out to carry out this study with the specific objectives of comparing the safety, the efficacy of TDLC with medical therapy, which is the mainstay of therapy currently in the country, in terms of the percentage reduction in intraocular pressure before and after treatment, to determine the safety of TDLC in terms of the complications that arise post-operatively, and then to assess patient satisfaction with treatment after the treatment, with the overall aim of improving the quality of life and visual function of the patients. So the study was a randomized controlled trial that was conducted over a 3-year period. Data collection took over a 3-year period due to certain limitations of the study that we'll highlight later on. The study participants included glaucoma patients either attending clinic at AKTH or referred to the facility that fulfilled the inclusion criteria. Now, patients who fulfilled the inclusion criteria were administered consent, and only those who consented to the study were now randomly assigned to receive either TDLC or laser therapy and followed up for a period of 3 months or 12 weeks after treatment at certain stated follow-up periods. The outcome measures of the study were essentially the 3 study objectives. However, visual complication, the main complication was visual loss, and we termed visual loss when there is a 2 or more reduction in So you can imagine.
Time was paused, so
you can see even partial visual loss, you could see the impact it had on all of us. So now at the end of the study, 124 patients' eyes were assigned to receive TDLC and 125 eyes were assigned to receive medical therapy. The main findings of the study are along the study objectives. We found out that about 78, there was significant reduction in intraocular pressure in the 2 treatment groups. However, the TDL So now our findings. The mean percentage reduction in intraocular pressure 12 weeks following therapy was significantly higher in the laser-treated groups compared to the medical-treated group. Now, the proportion of patients with intraocular pressure less than 20 millimeters of mercury was also significantly higher in the laser-treated group. It's important, however, to say that slightly higher proportion of patients had visual loss in the TDLC group. However, the difference was not statistically significant. Patient satisfaction was also significantly higher in the laser-treated groups. This graph shows the percentage reduction in the intraocular pressure between the 2 groups. The upper line is for the patients in the TDLC group at the 1 week, 2 weeks, 8 weeks, 4 weeks, and 8 weeks, and 12 weeks after treatment. This compares the vision categories of the patients in the TDLC and medical treatment groups before and after treatment. There was no significant change except for the small proportion that lost vision in the laser group, which was not statistically significant. This graph compares patient satisfaction between 2 groups, which was also higher. Now, our findings compare favorably with findings across the globe. I forgot to tell you that this is the first study in Nigeria that has done a randomized controlled trial on RCT, and prior to it, only one study has been done in Nigeria trying to demonstrate the efficacy of TDLC, and that wasn't a randomized study. And even though there is data about the effect and safety of TDLC in the Caucasians, there is paucity of data in Africa, so that was part of why we did the study. Our findings were comparable to findings by Abdul et al., which was done earlier in this country, but we even had lower post-operative intraocular pressure in our own findings. However, duration.
Round of applause for her, please.
Yeah. So can we take some questions? You didn't warn her that she has only 1 minute left. You did, yeah? Okay. All right. So let's take questions. Question from the audience, please. Any question? Okay.
Thank you very much. You know, the medical therapy and the laser are not free. You had a lot of patients, isn't it? So when the patient comes, and usually these patients are poor, this laser were they offer free to the patient or the patient paid? So in other words, was the grouping of the patient determined on the pocket, out of pocket? Because if I can't afford laser, I cannot go to the laser group. Or you paid, or you got this for all the laser. This is based on assigning the. Thank you.
Okay, I have a few questions. This is a randomized control trial. Was it registered? You must register every clinical trial you're doing. It's an RCT. Yes. So you must register and you must follow the appropriate guidelines for conducting an RCT. Okay, and then 2, randomization wasn't visible in this study. You know, we're supposed to hear things around allocation concealments and stuff like that, but I didn't think I heard it. So I'm thinking this has fallen short of an RCT, so it's a pseudo experiment. Yes, you're comparing 2 groups, but there's randomization, which is a key component of your trial. And then, was there any blinding at all in this study? Or people were purposely put in group A or put in group B? Like Prof said, maybe was it based on cost or was it based on what they wanted, either the conservative treatment or the laser? So I would like you to answer that. And then, okay, I think that is all from my end. Thank you.
Let me just add, has there been studies earlier that shows that laser is more effective than the medical treatment? And if the answer is yes, then how is it ethically right for you to assign people to regular treatment instead of giving them laser, when you know it is more effective?
Thank you. Thank you for the questions. Regarding the cost of treatment, interestingly, the cost of treatment is about 10,000 per treatment episode, and from earlier studies, it takes like a treatment episode can control intraocular pressure for like 1 to 3 years. However, for medical therapy, in order to control intraocular pressure in patients that fulfilled our inclusion criteria, which is a pressure of 28 millimeters of mercury or more, you need nothing less than 2 or 3 anti-glaucoma medications, which will cost nothing less than 25,000, and that is just for a month for the patient. So that is, we didn't use that for randomizing the patients. The inclusion criteria, once the patient fulfills the criteria, having advanced glaucoma in the eye, there are certain inclusion criteria. First, the attending glaucoma specialist first certifies that the patients can receive either laser treatment or medical treatment. So it is this criteria of patients that are now referred to the researcher, and also from various centers across Kano. So now when these patients come, sorry, there was randomization, time didn't permit. What we did, we generated a set of random numbers 1 and 2 using the Excel rand between function. So now this 1 and 2 were put in brown envelopes and sealed. Now these brown envelopes were then inserted in white envelopes, which are numbered from 1 to 250, which was the initial sample, which was the sample size. So now these envelopes were arranged, and now each of these patients that the consultant refers, now we administer the glaucoma information sheet, which tells the patient about its stage of glaucoma and that he is free to receive either laser therapy or medical therapy. Any patient that shows preference for medical therapy is excluded at that point. Only patients that say, I'm okay with any of the two, then we ask the patient to pick the topmost envelope, and that automatically is the patient's number. Then we open the envelope. If the number in the envelope is 1, we assign to medical therapy, and if it is 2, we assign to transscleral diode laser cyclophotocoagulation. That's how the randomization was done. Then regarding whether there has been studies that have demonstrated efficacy of medical treatment over laser. Now, the historical background, initially transscleral diode laser cyclophotocoagulation was restricted for only painful blind glaucomatous eyes that do not have visual potential. However, in the last decade, studies have started showing that modifications in treatment settings have made it possible to use the treatment option in patients that still have seeing eyes and have advanced glaucoma. So a lot of studies have been conducted.
Thank you. You know, we have this superstition in Nigeria that if you are traveling, don't tell anybody. I hope you didn't tell anybody you were traveling. All right, we're fast moving to the end of this phase of the competition. And next we'll be taking contestant number 3 for his presentation. The slide. Your point. Okay.
Good afternoon. Good afternoon, my examiners, colleagues, and the audience. I'm very happy to share my study with us today. I did a study on hyoscine N-butyl bromide for the shortening of active phase of labor in the primary gravidae, a double-blind, randomized, placebo-controlled trial at the University of Oyo Teaching Hospital, Nigeria. As a way of introduction, we know that labor in the humans can be complicated by delays or dystocias that could culminate in prolonged labor. Now, this prolonged labor has its untoward effects both to the fetus and the mother, more so for the primary gravidae, whose uterus is inexperienced, labor naive, and prone to incoordinate uterine action. This could culminate in fetal exhaustion, acidosis, and other complications. Now, even though there was a success story from O'Driscoll et al. In 1969 when he did a study on primary gravid women using oxytocin, Gupta and a colleague in 2014 realized that there was a 20% lag. 20% of primary gravid women who had primary dysfunctional labor did not respond to oxytocin, and so left a gray area for study. Again, I also discovered from And so I was concerned, what could be the problem? And I looked up the web. I realized that hyoscine butylbromide has been studied mostly outside this country in the white population. Very few studies have been done in Nigeria, really. More so, focusing on primary gravid women. So I set out to do this study. The aim of this study was to assess and evaluate the effect of hyoscine N-butylbromide in the active phase of labor in primary gravity, with specific objectives of, number one, comparing the duration of the first, second, and third stages of labor in the intervention and control group to compare the neonatal outcome in the postpartum hemorrhage, and also to assess for maternal side effects. The design was a double-blind, randomized, placebo-controlled trial involving 100 consenting women who met a selection criteria and were randomized into the two groups, 50 on each group. They were given, at the active phase of labor, from 5 to 7 centimeters. They were given hyoscine N-butylbromide or sterile water for injection. We used the visual analog scale for pain to assess pain, and then the study proforma were used. We followed them up till delivery, and data were collated and transferred into the statistical package for social sciences version 25 and analyzed. Continuous data were analyzed using the student t-test, while categorical data were analyzed using the Fisher's exact or the chi-square test. And results were represented in tables. The flow chart was represented using the consort flowgram. The p-value was put at less than 0.05. The result was a significant reduction in the duration of active phase of labor in the intervention group compared to the control, and also a reduced need of labor analgesia in the intervention group compared to the control group. The only significant side effect in the intervention group was dryness of mouth. I assessed 4 of them, dryness of mouth, but this was mild and tolerated till delivery. So the conclusion was that hyoscine N-butylbromide was effective in reducing the duration of the first stage of labor in primary gravid women, with added analgesic effects and reduced fetal-maternal outcome. And the recommendation is that primary gravid women should be given intramuscular 40 milligram of hyoscine L-butylbromide when they come in between 5 to 7 centimeter os dilatation, with the aim of achieving expedited delivery with reduced fetal-maternal outcome. And I recommend this for even Shalina. I haven't seen that in your drug list. Please include hyoscine N-butylbromide. Give it a name and let us use it to help our women in this low socioeconomic environment that we find ourselves. Thank you so much.
Thank you. Can we have a few 2 questions for him from the audience? Anybody? Question from anybody? Dr. Ademolu, can you ask a question, please?
Gas score like between the intervention group and your control?
Thank you, sir. The ABGAS scores were comparable. They were optimal, above 7/10 for all the babies. Sorry, I didn't project that. I had 5 minutes, so I had to just concise my presentation and flow. They were called comparable. Every other objective were comparable except the duration of the first stage of labor, and then the need for analgesia and the maternal side effect, where we had more of dryness of mouth.
I guess all the primaries were having cephalic presentation, no abnormal presentation.
Yes, sir. That was an inclusion criteria.
So the issue of dilatation, you did the assessment for all the patients or different?
I had research assistants who were trained.
Did you standardize the size of their fingers?
Yes, we used a cervicograph in our facility that is measured. Yes.
Their fingers?
Yes, sir, with the fingers.
So if you take a range of 7 to 10 in terms of dilatation, and you are given the Boscopan at different for the 2 groups, you must, for it to make a lot of sense, you must match centimeter for centimeter of the dilatation, not a range. Yes, otherwise, you may be putting the 10-10, the extreme of the other group in one group, and the other are having 7. Some are even 6. Somebody will conclude as 7, and you have a range about 4 centimeter difference. So if you have the data,
yes,
look for it actual centimeter by centimeter, not a range of 7 to 10, 5 to 7.
Okay,
otherwise, you may miss out some of the significance. Thank you.
Understand, sir. Thank you.
Thank you. Next.
All right, a round of applause for him. Okay, so while we get the last presentation ready, just the last presentation, Farmer will come up quickly to recognize some of our guests in the house.
Still standing on existing protocol, permit me to recognize Dr. Adeola Ajibare, consultant cardiologist from LASU. You're welcome, sir. Welcome, sir. Dr. Adebayo SK, consultant Ops and Gyne, GH Randall, and medical director, Day Spring Hospital. Dr. Adebayo. Step down. All right. Then also want to welcome Dr. Adediran Aramide, consultant endocrinologist. He's the HOD MOPD, GH Ifakojayi, General Hospital. You're welcome, sir. Are you ready? Oh, also please permit me to also recognize Dr. Yetunde Oyalowo, the MD Market Doctors. You're welcome, ma'am. As usual, she's a friend of the house, always with us. If we move this program to Gombe, she will go with us. Right. Thank you. I hope so far so good. I hope we are enjoying ourselves. For those that take Asun, is on the prowl. Asun is on the prowl. Please don't endeavor to beacon so they can give you yours. Dr. Miriam Abdullahi, they can package yours. You can take at night. Please. Prof, no Asun for Prof too. Professor Samaila, no Asun for you. Please give your dose to Dr. Afid. All right. Is it ready? Okay.
Okay, so we come to the final presentation for the day. And the presentation by contestant number 12, Dr. Omolara Odun. Is it Odunsi? Okay, I didn't see it fully. A round of applause.
Good afternoon, everyone. I'm presenting my research titled The Relationship Between Craniofacial and Upper Airway Morphologies and the Risk of Obstructive Sleep Apnea in an Adolescent Orthodontic Population, using this outline.
Sorry, a little technical itch. You reside in Lagos. just a couple of minutes, we'll think it's a little problem with the system, yeah. So as the presentations were going on, you know, I enjoy a lot of stories, funny stories at that. And as the presentations were going on, I had stories for almost every presentation. But because, like I said, because of the brevity of time, I couldn't start telling the stories. Okay, please make yourself comfortable. So I mentioned the story about the dentist. Actually, a visit to the dentist. Okay, they don't want my story, so we're back online. Okay, Dr. Odusin, people. A round of applause for her again.
Thank you very much. Okay, I'll be using this outline, and obstructive sleep apnea is a common sleep breathing disorder which is characterized by frequent episodes of breathing cessations and snoring during sleep. And then when left untreated can lead to some more severe consequences. Some of the etiology is multifactorial. However, some risk factors have been identified, which include craniofacial and upper airway morphological abnormalities, particularly the craniofacial abnormalities that will cause crowding of the upper airway or posterior displacement of the tongue, such as seen in the retruded mandible, increased soft palate size, and so on. The lateral cephalometric radiograph, which is a reproducible standardized radiograph, one of the standard records in orthodontic diagnosis and treatment planning, can be used to assess these morphologies. And the X-ray is analyzed either digitally or manually with the points as shown in the photo. So the diagnosis of OSA is by a combination of sleep history, examination, as well as confirmatory polysomnography. However, this polysomnography is not readily available. So there has been sleep questionnaires such as the modified sleep bank questionnaire, which have been developed for routine screening amongst general population as well as in sleep clinics. The literature search revealed that 18 to 23% of adults in Nigeria were at risk of developing OSA, and also showed that routine screening with these sleep questionnaires will facilitate early diagnosis of this condition. Also, orthodontic intervention has been shown to reduce the severity of this sleep condition. This slide is showing us some of the orthodontic appliances that have been used to protrude the retruded mandible, whereby the lower jaw is positioned more backwards in such individuals, leading to crowding of the upper airway, maybe by displacement, posterior displacement of the tongue, or so this study aimed to assess the risk of OSA and determine the relationship between the craniofacial and upper airway morphology, as well as the risk of obstructive sleep apnea in an adolescent orthodontic population, and the specific objectives are as listed. The design was a prospective, comparative, clinic-based study carried out in the orthodontic clinic here in Lasut, and consecutive adolescent patients who presented for orthodontic intervention were screened for the risk of obstructive sleep apnea using the modified stop bank questionnaire. Subjects aged between 13 to 19 years who had no previous history of orthodontic treatment or pharyngeal or jaw surgeries were recruited. So based on this screening with these questionnaires, the questionnaire was scored and graded, and based on this, they were divided into two groups. The test group, the OSA risk, and the non-OSA risk, which was the control group. And a total of 46 subjects were recruited, consisting of 23 in each group. So all subjects were clinically assessed and subjected to this lateral cephalometric radiographic technique, and data generated was analyzed using the statistical package for clinical sciences. Tests of association of clinical parameters was done using Pearson's chi-square. Independence test was used for comparison of the cephalometric parameters, while the correlation of the cephalometric parameters with the risk of OSA was done with Pearson's correlation. A significant level was set at P less than 0.05 for all subjects. And the results, the research showed that the lower SNB value, which is suggestive of a retruded mandible, was associated with the risk of developing OSA. Also, a higher NSH angle, as well as increased tongue length, tongue thickness, and greater soft palate area. In conclusion, findings from this study reveal that craniofacial and morphological airway craniofacial morphological variations are associated with the risk of developing OSA, and hence we recommend that routine screening of patients, orthodontic patients, should be done, as well as the inclusion of orthodontists in multidisciplinary management of OSA. Thank you for listening. Special acknowledgement to my supervisors. My slide is not complete.
Thank you for the presentation. Can we have 2 questions for her from the audience, please? So, Dr. Odusi, what is new about your study? What is new that we didn't know before?
Okay, sir. Thank you very much. This study is actually to bring to our knowledge that the risk of obstructive sleep apnea can be detected amongst routine patients attending orthodontic clinic for routine diagnosis. Orthodontic clinic is where we correct jaw and facial abnormalities as well as the teeth using braces and appliances that modify growth, that that use the orofacial, the facial muscles. We alter the functional environment.
So you are saying
move.
that these are things that are known before, yeah?
Yes, sir.
You are just reinforcing it, have you?
Yes, sir.
Thank you very much. Any more questions?
I think part of why we are here is, to also prune your work and make it publishable.
Yes, ma'am.
Okay, so when you hear study design and you put, I don't know what I saw. I think I saw, what was your study design again?
Prospective comparative study, clinic-based. Yeah.
Okay.
Yes, sir.
So that is not a known study design. So we know different study designs, but try and get the study design that is applicable to your work.
Okay.
Okay, so there's nothing like prospective. Is either a cross-sectional or is a cohort or is a case. There are different names for different studies.
Yeah.
But I think what you simply did was a cross-sectional analytical study. Did you look for potential confounders in this study?
Yes, because one of it was the mixed dentition stage, whereby they still have the baby teeth in their mouth, and so those ones were excluded. That's why we included adolescents between 13 and 19.
So why am I asking that? So you must, before you even get to the point of analysis, you should have identified potential confounders which you would exclude. That's why it's an exclusion criteria. These are possible confounders that could bias your study.
Yes,
and then at the analysis stage, you must also work on dealing with confounders when you have finished collecting the data. Did you do that? Did you do a regression analysis at the end to say these are independent risk factors for OSA in this work?
No, we didn't do that. But at the inclusion criteria stage, we excluded them. But the purpose of time, it was not possible to include everything in this presentation.
Okay, but it's important for publication purposes to deal with confounders at the point of analysis.
Okay.
Because whether you like it or not, you can say, oh, this is associated with this, but it's actually a confounding variable. Okay. When you now subject it to logistic regression or any regression analysis, it picks out what is real. Okay? It picks out the true picture of these are independent risk factors for OSA. Okay, so that must appear in your work. Thank you.
It's very important because some of the measurements we are giving as being significant may just be because the person is obese. His BMI is high, his height is also that. That's what she says is very important. There are so many other. She saw that it's purely on those morphological variation that is given the OSA, not because they have other risk factors for OSA.
Yes, sir. Also, the cephalometric values, they have the normal standards. So we have the normal ones for Nigerians as well as the normal. Yes, sir.
Thank you very much.
Thank you.
I think we've come to the end of the presentations.
So a round of applause for all our presenters today. Okay, so we'll be moving on to the next stage of the competition, which is the rapid fire, where I said that we'll be looking for the Toby Amazons amongst the consultants. That's those with very fast reflexes. Here it goes beyond what you know to how fast you can respond to the queries. So we're trying to put things together. The last two editions, we actually did, we used manual buzzers. This time around, we're using electronic buzzers. We're moving from analog to digital. So we're going to exploit digital technology. And so that means that you should have a working gadget. I believe nobody is still using not 9 knots. Of course, nobody is using not 9 knots. It's either an Android or an iPhone. Very soon, we'll share a link with you.
All right. Sorry, please, for the next stage, please, we expect you to bring out your phones, please, just like we were advised. Please, we would share the internet connections with you. Right.
So we're using the same internet so that nobody is using 6G, giving them advantage over others.
So we're going to, I'm going to give everyone the privilege of 5G. Right.
Ayo, what if my phone operating system is faster than yours?
So just give us a few minutes to put that together. So the story about the woman who went to the dentist and she wanted to find out how much it would take to do an extraction. And she was told by the dentist that it would cost 80,000 per tooth. 80,000 naira per tooth. And she felt the amount was outrageous. So she said, what can I do to cut down cost? I can't afford 80,000 naira. Well, the dentist thought through it and said, okay, what we could do is we will not use analgesics. Analgesic first. Okay, local anesthesia. No, it's my story. Let me tell the story. He said we'll take out the analgesics, right? So we will carry out the operation with the anesthetics and all that, but we will not give you any analgesics and you'll pay 60,000 naira. She felt 60,000 naira was still a lot of money. So, is there anything else we can do to bring out this cost? It's a lot of money, doctor. He said, okay, what I can do is I'll take out the anesthetics. We won't use any anesthetics. We'll just yank out the tooth and you can go and you pay 20,000 naira. Well, doctor, 20,000 naira. You know women now, when they go to the market. 20,000 is still a lot of money. Anything else at all that we can do? Doctor said, okay, one last option. I will allow my apprentice to do the extraction, right? We won't use analgesic. We won't use anesthesia. And you can pay 10,000 naira. He said, okay, 10,000. I think 10,000 naira is affordable. So I'd like to book an appointment for my mother-in-law next week. You can understand why she was pricing. I wonder what it is about women and mother-in-laws. Somehow they wish that the man they want to marry does not have a mother. I wonder how he came into the world. Because there's just nothing about mother-in-laws and wives. Are we ready? A few more minutes. Okay, so while they're on that, someone had a presentation that had to do with antibiotics, right, among the presenters. The use of antibiotics. And so there was this story of a promiscuous young man that went to China. And when he came back, he caught some disease. And of course, went back to America and went to doctors. The first doctor he went to diagnosed, and he didn't know what it was because it was unusual. So he told him to go and run some tests. After the test came back, after 2 days, he looked at the test and he said, oh, no wonder. He said, you have Mongolian VD. Say, it's not common around here, and so it's not something we have experience with. That the only solution we know is amputation. The young man protested, amputation. Of course, you know the implication of that. He said, no, that, isn't there any other solution? Doctor said, unfortunately, that's the only solution we know. Okay, let me explain for those of you who didn't catch on to that it affects the third appendage in the lower part of the body, if you understand what I mean. So the doctor said they had to sever that off. Well, he went to so many doctors and it was the same feedback, we had to amputate. So he complained to a friend that I'm having these challenges and doctors are saying they have to amputate. And so the friend advised him to go to a Chinese doctor because, of course, China was where he carried the thing from. So he went to this particular Chinese doctor and explained everything to the Chinese doctor. And the Chinese doctor said, after examining him, he said, this is Mongolian VD. He said, yes, I already know that. He said, what's the solution, doctor? He said, an American doctor told me that he had to amputate, but, I can't afford amputation at this time in my life. He said, the doctor now laughs, the Chinese doctor. The American doctors, don't mind them. They always like to make money. They tell you you have to do surgery. Say, you don't need to do surgery. He said, thank you so much, doctor. He said, yes, you don't need surgery. He said, just wait for 2 weeks. It will fall off by itself. Are we ready? Okay, that's the thing about technology. It takes a little while to catch on, but once you catch on, everything will go on autopilot. Okay, majority are connected. If you have heavy documents in your memory, you may need to transfer it to your drive. Then you go back and transfer it back to your phone later. It will help the speed of your phone.
The operating systems are different. So the rates at which, how quickly you get it. Do you understand? It's different. Maybe let's have something that can be the same level of constant. Yes. So,
So, contestants, your focus should be on the white background slide. That is where the questions will appear. Your focus should be on the white slide with the white background, written end of round 1 contest. Questions will appear here.
Oh, so please, you need to enter into the room.
Maxine, can you display the room code?
Can we give the instruction for this session?
Yes, please, sir.
Although I think because they're using different phones with different operating system, it will not be fair, really, because my operating system may be faster than yours. So the way to do it in future will be for you to give them the same device. You understand? It may not necessarily be phone. There are these devices that are used to answer questions. So those devices will then be uniform for all of them. Okay?
Okay, sir. But you will agree with me, sir, that life is not so fair. By birth, we're all born with different operating systems, if you understand what I mean.
You see, because this is not a uniform group. You have orthopedic surgeons who have plenty of money. You have pediatricians who really don't have money. They have to give money to their children. So that's not a uniform group,
Feedback well taken, sir.
And you have public health physician who earns a lot of money from WHO and co, like the... Okay.
Okay, some have iPhone 15, I understand. Okay, feedback well taken, sir. Okay, so I'm going to hand over to Mr. Maxine, who is going to give the contestants the instruction on how to participate.
Maxine, the room code, please.
Okay. Good afternoon, everybody. At this point, I want to believe everybody having internet on his phone. So if your phone is internet enabled, please follow these steps to get to the buzzer's place. First of all, you have to go to Google. Then when you are there, search for multi-buzzer. As you can see on your screen, the first link that will appear is what you have to click on. This link. After that, this page will open. Please, on this page, the room code is what I'm going to display now.
Who is giving them? Why are they writing? Okay.
Okay. So if you are in your number, your username, please use your seat number as your username. Okay, so they say internet is slow, and it's 5G actually, 5G. But it's 5G MTN. So are we good? Okay, so I think the contestants are resolving to the old faithful network they are using. We made provision for MTN 5G router, but...
Please, can we be announcing the rules?
Yes, please, sir.
That...
please, contestants, listen, please.
You do not press except you know the answer. Or you think you know the answer. If you press, you are supposed to answer within 3 seconds. If you have no answer, or you give a wrong answer, you are going to get a -1. We don't want to guess us. Yeah, we don't want you to press and then nobody else will be able to press, okay? You get -1. If you get it correctly, you get 2 marks, okay? But if you get it a little big and we judge, okay, we can give you half, I'll give you 1 mark. Do you understand that now? So you either get -1, 1, or 2, okay? That is the first step. So we are going to add this mark to the mark of the dissertation, okay? And we hope we won't have a tie. Anytime we have a tie, then whoever scores the higher mark at the dissertation will be the best person, since this is more of the dissertation. If they're still tired, then would they consider this stage we are doing? Is that? Yeah. Okay.
So let me add something. I think it's very important what the chairman has said, because this is rapid fire. And some people have just quicker response. Some have bradykinesia. So we don't want somebody, nobody has Parkinson's here, don't worry. Nobody has Parkinson's disease, but we don't want somebody who is want to outsmart the other 14 contestants. His own is, as soon as you bring the question, bam, he has pressed it, so that he starts processing and guessing. That's why this penalty is there. Otherwise, one guy will just say that before the question, he wants to say, bam, 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 and because he wants to take the option. Because you don't have opportunity of answering the question, all of you. It's first finger first. Because this electronic, once somebody presses first, even by a fraction of seconds, it prevents the others from pressing, and it will show it's table 7 or 4 or so. So the penalty is because we don't want somebody to just be there, just as a fast responser with nothing in the head. He has not processed even the question. He's only then he will have 3 seconds to read the question. So that's the reason why I think you understand the rationale. So be sure that you know, because if you keep quiet for 3 seconds or you give a wrong response, you get -1. So even if you don't answer throughout the session, we go and remove from your dissertation. No, it's very important so that you understand, because you will say that I didn't answer anything, so why will you subtract from? We'll go back to that dissertation and remove. Thank you.
Just if you got 60% in dissertation -10, then that means you get 50. So you should know that this session may determine whether we are going to deduct mark from what you have already gotten from the dissertation.
Okay, thank you.
3 seconds, Abi. Or is it 5?
No, it's 3 seconds.
No, let's do 5 seconds. 5 seconds is not much.
No, we are projecting the question for some seconds. It's the period to answer.
Okay.
Even 5 seconds is even too much. You've already seen ABC, you are saying it's answer.
So once you press, you should answer in 3 seconds.
3 seconds.
Who is going to be reading the 3 seconds?
How long are we projecting? How many seconds are we projecting the questions?
No, he would announce.
Is when you finish.
So the way to go is once you announce the number, you have 3 seconds from there.
Exactly. Once
All right.
he goes on board, you time 3 seconds. Who will be timing?
Once he announces the number to answer,
3 seconds.
Yes, 3 seconds.
All right, please, we want to be sure that every buzzer makes that sound. Please,
Femi,
press yours.
Hello, Mr. Ayo.
Yes.
Femi.
So before we start, please
Femi.
ensure to turn on sound.
Okay, please.
Turn on sound.
Turn on sound, please.
Femi.
Look to the top left.
Please. He has pressed. Try to.
Okay, I'm trying to ensure that everybody is active in the room. So if I call your number, please pause.
Reset now, please.
We're ready with the story. Okay.
No, you don't want to reset.
Okay.
So what of the sound?
Then we should. I suggest we do a test run.
No, it should be a
We do a test run, just a phantom without projecting the real questions. Let's just see that they get this pressing issue right. Thank you. Use the test right. Everybody try.
Turn on sound, please. Check up there. You see turn on sound. On. Okay, please press. No. I wanted it. Please reset. I wanted it number by number so that we'll be sure. Please reset. Oh, yeah, press. No. His own is not responding. Turn on sound. Where is it?
It's already on. I turned it. That's why it says turn on.
It's not coming on. Turn on.
It's on already.
Yes. But it's not sounding that one. No, yours should be volume. Okay. Oh, yeah, press it. Okay, please. Number 2. Don't sound it. Please reset. We want every sound to come out so that we'll be sure. Because that's what we're... Number two. Please reset. Only number 2, please. If your number is not called, please don't boss, please. Reset. No, it's not coming out from his.
It's not coming out from my device.
Yes.
Volume is maximum.
Is it turned on?
It's turned on.
Okay, please pause now. No, something is on. It's not. No, it didn't sound. It He didn't. No, they. Please reset. It's showing, but it's not. The sun is not coming out. Okay, please reset. Number 3. Not sounding like
It's after they reset it, I now bought and
no, from your own end.
Let me try.
Please reset. Okay, is there? What of yours, though? We have 4.
The volume is at the last bar.
The sound didn't come out here. Please reset. The sound didn't come out from you. Which one is that? Number 4.
It's fine.
It's fine.
Problem.
We can go on.
No. Let them go all through.
Okay. That's yours. Okay. What of 6? 6, right? 7. 8.
It's too loud, please.
No. 9. No, the buzzer. Please reset. That's where it is. It didn't come out from yours. Press again, please. Okay, all right. Number 10 now. Press. Okay, all right. Number 11. Okay. No, it's on. Sorry. No, please reset. Number 11 now, please. Okay. All right. We've done that. Okay. Number 13 now, please. Please don't press. Number 13 only. Number 13. Okay. Number 14, please. Okay. Number 15 now. It doesn't matter since it's out there. And it will show. The number will show. Oh, yeah. Number 15. All right. So, okay. Sorry, Doc.
Number 12.
Okay.
Number 12.
Number 12. All right, Doc. It's okay. All right. I hope we are guided. I hope we are guided by the rules now. No issues. +2. Sorry? The computer to detect, check, give them the answers.
No.
They're supposed to. They don't have the computer.
Give them your own computer where they have the question.
No.
Prof, let's give you the computer.
We'll give you the computer.
No, Prof, we just wanted to keep the answer within the marking scheme. We don't want deep ones. That's why we're giving you the computer.
Chairman should come here then. For this exercise, Chairman, we don't want to put the chair halfway. You also come back. So the two point. Yes.
The moment they press, the first number on top is the fastest.
Yes, on top of him.
So let me reiterate again. I will call the attention of the judges that we are about to commence. I would also alert you that we are about to commence. Then after which I will flip so that the questions will appear.
Let's do a test run.
After that, when the number appears,
Benga, the MC would call the number. You have 3 seconds to respond when he calls your number. That's how it will go.
Okay, we'll just do a test. Just test run, please. Everyone is involved, so get ready, please. What is the capital of Taraba State?
Wait.
First number is the fastest.
Number 2 is the fastest. So you answer the question.
I have -2 now. 3 seconds has gone. No, -2. You didn't answer in 3 seconds.
You have to answer it.
Prof, amnesty, please. Prof, amnesty, please. We are still doing a test run.
All right, I hope we get that. Please, the fastest finger, that's the number that will be on top. Do we do another one? Another test? Okay, everybody get ready. Please reset. Everybody get ready. Right. I want a general question. I know medical. Okay. Capital of Kwara State. Please. See.
You see, there is confusion. You didn't call you, and
you are not called.
Please
you lose a mark.
Wait till your number is announced before
your
you
number
answer.
has to be called.
If somebody responds without being called, it's also part of the next.
Please wait for your number to be announced before answering.
Please. The panelists will call out your number. Number 7, answer. Please. Then you have 3 seconds after that.
They will time the 3 seconds.
Yes.
So who is doing the timekeeping?
Chuba.
Okay, he will hit the bell or what?
Yes.
Okay.
Sorry, Viren Chupu is at work. Give us some time. Somebody has been logged out.
Oh, so how many questions are there?
Is that their discussion?
Logged out?
Well, I can assure you it's within 25.
Somebody logged out? Ah. Wow.
Maxine, room code again.
Okay.
Room code again. Room code. Hope you have it.
Sorry? You've been logged out.
Wow.
Your number is not there.
Please confirm the contestants are 15. Please quickly check.
Some numbers have been logged out.
Confirm that the contestants are 15 in number.
Understand 2, 5.
Confirm that the contestants
Are you
are
back?
up to 15.
5 has been logged out. Huh? And that's why I said it should. Okay. Please, Maxine, please reset. Maybe the numbers, all numbers will come back. Please reset.
No, he has to know.
Huh? You've seen your number. Okay. Is there? So please reset. No? No, the next question you would have now.
Which number is it?
As long as the moment you see the blue balls, if you reset, you see the blue, deep blue balls. That's the one you know you are ready.
Maxine, reset, please. Let's see number 4. Just focus on the buzzer. Let's take a roll call to be sure everybody is here.
No. I think maybe the last time we didn't go.
Any other person will log out now?
Right. No.
Please, 5.
Because you didn't go.
5.
So by the time you refresh,
Yes.
it and end.
Number 4. Maxine, reset. 4. Which number again? Number 2. Number 1. Number 3. Number 15. 9. 10. 11. 12. 13. 13. Shield, okay. 14. What happened to the sound? Can we take that 14 again? Why is the sound? Okay. So, judges, are you ready?
Yeah, we're ready.
Can we ready? No test question anymore. We are ready, right?
We've done that.
Judges, are you ready?
All right, so over to you.
Remember, do not answer until your number is called. Judges, are you ready?
Yeah.
Contestants, are you ready?
Number 13. Correct. 2 marks.
Judges, are you ready? Yes. Contestants, are you ready?
Number 1. Abi? No.
1, yes.
1. Correct. 2 marks. Yeah.
Judges, are you ready? Contestants, are you ready?
Number 2. We can't hear your
Time up.
answer.
Was he answering?
Wrong. -1. Prostate cancer is the answer.
Judges,
Next.
are you ready?
Yes.
Please, contestants, speak louder while you are answering.
You need to speak up.
Just speak up. Contestants, are you ready? Audience, please.
Number 1. Sorry? -1.
Ms. Ayo, please, can you give the judges an additional mic for the online audience?
Well, okay.
The online audience cannot hear you well.
The audience can't hear us well.
Online.
Oh, sorry.
We have a lot of people online also.
Okay. Is it that this is the one that is connected? Okay, we can go ahead now.
Judges, are you ready? Contestants, are you ready? Please, contestants, remember to speak loud.
One.
Correct. 2 marks.
Judges, are you ready?
So P. falciparum for responsible for severe malaria.
Judges, are you ready?
No.
Please reset. Please, warning contestant 10. Warning contestant 11.
We have not asked the question. We've done this already, so just wait for the next question to show.
Judges, are you ready? Contestants, are you ready?
Number 11. We can't hear the answer. Sorry? Wrong. -1.
The answer is range.
-1.
Judges, are you ready?
11, yes. Yes, go ahead.
Contestants, are you ready? Audience, please. Audience, please.
Nine. Speak up, please.
-1.
-1.
Malignant melanoma.
Yeah. Can you? Okay. We need a microphone for them to hear. We do.
But that's a malignant melanoma. We've been saying the answer. Yes.
Georges, are you ready?
Yeah.
No, it's difficult to follow because mic might be
Because
there,
it's timed.
so the 3 seconds cannot be, they just have to speak loud.
Yes.
And I will repeat the answer from this end. If you say you will give them mic, it may be 1 kilometer away.
Yeah.
So I think they should speak loud and then I will repeat what they said. Either correct or wrong. Thank you.
Please remember, I might not hear you, so to avoid me saying time up, speak loud. Judges, are you ready? Contestants, ready?
Number 2. It's 2 now. Number 2. No, it's Snelling's chart.
-1.
-1.
Warning, contestant 15.
Even if you press, the number on top is the one that boosts first. So we take that number because we may be 3 going down and some numbers down. So the judges are deciding here because the one on top is the one that boosts first. Thank you. So this is Snelling's chart. Used for visual acuity.
Judges, are you ready? Contestants, ready? Audience, please.
Number 6.
Wrong.
Wrong answer. The answer is 5. There are 5 waves in normal ECG: the P wave, the Q wave, the R wave, the S wave, and the T wave. So the answer is 5. It's wrong.
-1.
-1 for 6.
Judges, are you ready? Contestants, are you ready? Audience, please.
Number 10.
Correct. 2 marks.
Correct. 2 marks. Hippocratic oath. The oath taken by physicians before they are being admitted to the profession is Hippocratic oath. So correct.
Judges, ready? Contestants, are you ready? Contestants, are you ready?
Number 10.
Correct. 2
Correct.
marks.
2 marks. The World Health Day is celebrated every 7th of April. 2 marks.
Judges, ready? Contestants, ready?
Number 1 is correct because E doesn't cause chronic hepatitis, chronic liver disease.
Judges, contestants.
Number 2.
Correct. 2 marks.
Judges, are you ready? Contestants, are you ready? Audience, please. Audience, please.
Number 13.
Correct. 2 marks.
Scatter diagram. Or scatter is yes.
Judges, are you ready?
Who pressed? Nobody should press. We have finished with this.
Judges, ready? Contestants, ready? Audience, please.
Number 1. Yes, correct. 2 marks.
2 marks.
Because 7th cranial palsy is the lower motor neuron idiopathic 7th cranial palsy is what we call Bell's palsy. And it gives the Bell's phenomenon also. Thank you.
Judges, are you ready? Contestants, ready?
Number 1
Wrong.
Age is wrong. The answer is gender because they are asking which one is a categorical variable.
-1.
-1.
Judges, are you ready? Contestants, are you ready?
Number 2. D.
Wrong.
It's wrong. The answer is C because you cannot use a random sugar of 7 millimoles. You need about 11.1 millimoles to diagnose diabetes. A glycated hemoglobin more than 6.5 is used by the ADA and even Nigerian Diabetic Association to diagnose diabetes. The wrong answer there is random of 7. You need 11.1 as also 2 hours postprandial. Thank you.
-1 for number 2, yeah?
Yes.
Judges, are you ready? Contestants, ready.
Number 1. Correct.
Correct. 2 marks for you.
Myopia, short sight, hypermetropia, long sight. Is that correct?
Number 1. Judges, ready. Contestants, ready.
Number 5.
No.
Wrong. This is a forest plot when you use meta-analysis or this, you compare studies. Survival curve is 2 lines that you see either you are surviving or this is a forest plot. It doesn't look like a forest anyway, but it's the forest plot. Thank you.
-1 for number 5, yeah?
Judges, are you ready? Contestants, are you ready? Audience, please.
Number 2. 2 marks.
2 marks for you.
Hydrocephalus.
Judges, contestants.
Number 1.
2 marks.
2 marks is triage.
2
You
marks.
sort out patient based on emergency.
2 marks for number 1.
Judges, contestants.
Number 11.
Correct.
2 marks. You can see the pencil shape, this in there, and the evidence of anemia there, which is showing hypochromasia and pencil cells of sickle cells. Thank you.
Judges, are you ready? Contestants, ready.
Number 11.
We can't hear you.
Wrong.
-1.
This is chronic subdural hematoma.
11. Candidate 11, -1.
Judges, are you ready? Contestants, ready.
Number 2.
So
Sorry?
we'll give you 1 mark. It's the laryngeal mask airway.
You put mask.
So just 1 mark.
Laryngeal mask airway. So 1 mark for you.
1 mark. Laryngeal mask airway.
Judges, are you ready?
We are going to the last question now.
Contestants, are you ready? Contestants, are you ready?
Number 4.
Correct.
Niclosamide,
2 marks.
correct. 2 marks. Niclosamide is an anti-helminth, while the other ones are analgesics. Thank you very much.
Okay, while the judges are putting together the scores, I hope it was interesting. I hope we enjoyed it. Only few doctors are answering. Dr. Hockman. I hope we enjoyed it. Right. Okay, please, while the scores are being put together, right, because the moment we get the scores, we'll go to announce are the top 3 winners. Please. May I call on Dr. Ademolu Adegbenga, please, to say something, give us some words of exhortation, right, while the scores have been put together. Please, Dr. Ademolu, please join me to welcome Dr. Ademolu. Please. Thank you, sir.
Yeah, Mr. MC, thank you very much for calling me here. You will all agree with me that it has been an exciting time. First of all, I want to congratulate all the finalists from number 1 to number 15. It has not been an easy road. You have come a long way. Well, definitely you are all winners on your own right. And as they are compiling the results, definitely the 3 best will be chosen. Anyway, the question is, we'll keep our fingers crossed. Who will run away with 1 million? Who will go away with 500,000? And who will go away with 300,000? When I was asked by the CMD to come and represent him, and also by the Director of Clinical Service and Training, I didn't know that I'm coming for a time of brainstorming and really... I didn't know I was coming for a very brainstorming and research-oriented exercise. But when I got in here, I almost became a judge myself, even though I am over there among the people. And I enjoy it all. I must tell you, from number 1 to 15, I really enjoy your presentation. On behalf of the CMD Lawsuit, I want to welcome you all to Lagos State on this occasion of a national program, which is the grand finale, organized by Shalina Pharmaceuticals. We are hoping that you will have a nice time, and which you have already. And we are hoping that whosoever emerges as the leader should be taken as the leader. And whosoever emerges as the 2nd place or the 3rd place winner should also be taken. So far, so good on my own side. It has been a fair play, a level playing ground for all the participants. So I wouldn't want us to show any signs of bias or anything, because the judges and even the audience, they have been very, very objective in their decision. I asked the convener a question before the program started. I said, now, the judges, have they gone through the dissertation of everybody? He told me no, meaning that they are coming across it for the first time. And I'll prove it to you. Even me, myself, I've not gone through your dissertation. I'm coming across them for the first time, and yet I was asking you questions. So I want you to clearly understand that they were objective in whatsoever they come up with. So let's keep our finger crossed. And as you go back after the winners are announced, I wish you a safe journey back to all your destination. Thank you very much.
Thank you very much, sir. Thank you. In the same spirit, let me call on Dr. Sixtus Ozumba. Please, let's hear some words of encouragement from you, sir. Please, a round of applause, please. Dr. Sixtus.
Thank you so much, Shalina. Thank you, the panel of judges. I am proud to say that I have been a part of this program since inception. I've attended all the editions. And we keep on improving and getting better. And my friend, the gastroenterologist, has always been there. So even if you come from orthopedics or anything, he's there to challenge you. And, you know, the last time I made this comment that maybe a very difficult examiner. But I also noted that such people find it difficult to fail you in the exams. So I'm happy that we have come a long way, and I'm happy that Shalina is taking up this. So, and I want to encourage us to continue to participate and improve on what we are doing. I hope that the last feedback of last year is going to reflect, apart from the conduct now, in terms of rewarding the participants. I remember we agreed that anybody that comes to this level is a champion on his own, and there should be a kind of reward for everybody that is here now in the finalists, because they are all winners. So thank you, and God bless you.
Thank you, sir. Sorry, also, let me call Dr. Ajayi O.A. Is Dr. Ajayi still around? Okay. Dr. S.K. Adebayo, please, let's have your words of exaltation. Please, round of applause for Dr. Adebayo.
Thanks so much, Lina. I've always associated with anything Shalina's organized. Because I look at so many things. If every pharmaceutical company can look inward and have programs like this, it will give a lot of hope for our younger ones. The first time I attended and I saw the whole thing, I said, oh, this wasn't in place in those days that we're doing our residency. It's one of the things that we even encourage the resident doctors to be more academically inclined. And that goes a long way, even passing the exams, the normal exams. So I think we really appreciate Shalina Academics for this. And it's been a very nice program. I forfeited a lot of things to be here today. And I'm happy that I'm here. And like I always said, I will always be with Shalina anytime, any day. Thank you.
Dr. Adebayo, we are going to give you a staff number, Shalina. All right, thank you. Please let me also call on Dr. Diola Ajibare, consultant cardiologist LASUT, to also say one or two things, please. Thank you.
Thank you very much. I also want to appreciate Shalina for this beautiful program. And like the last speaker said, if you had had this when we were writing part 2, it would have helped us in passing the exams. At the same time, it would also help us to publish very early. I remember that I wrote my part 2 2015. The first paper I published from that dissertation was in 2021. So I want to appeal to Shalina, just like the other speaker said earlier. Anybody that has gotten to this stage should also be encouraged. I want to appeal that each of these people, by the time they want to publish their wonderful dissertation in terms of publication, Shalina should help with the article publication fees. That would encourage them to publish, these wealth of experience. Thank you very much.
Thank you, Dr. Ajibare. Thank you. Please let me call on Dr. Francis Akimboade. Dr. Francis Akimboade, please. He has always been a friend of yours. Let's hear from you, sir. Thank you. Please, a round of applause for Dr. Akimboade, please.
Thank you very much. I appreciate Shalina for always providing very effective, efficacious, and cost-effective drugs. Take Shalbactam, for example. Shalbactam is a brand of ceftriaxone that is very, very effective, is beta-lactamase resistant, and is cost-effective. It's not so expensive. And a lot of patients benefit from it in our hospital, Lagos Island Maternity Hospital. I appreciate Shalina Healthcare for their programs and for encouraging the young ones. And I wish all of you all the best. And I pray that Shalina will go higher in Jesus' name. Thank you.
Thank you very much. I don't know if Ani Baba is still around. Ani Baba, please, we would like to hear from you too. Has he left? So, Dr. Ololakbo Nuruddin. He stood up. I saw him now. Sorry? Result is already here. Still putting it together using Excel. Femi, we're using VAR. The VAR expert is coming. I don't know if any of the contestants will want to say anything. Any of the contestants, please. We'd like to hear from you too. Please. Any of the contestants? All right, thank you. Please, a round of applause for Dr. Akon. Thank you.
Good afternoon once again, our examiners, colleagues, and the audience, and indeed the organizers of this program, Shalina Healthcare. It's a privilege actually to be here. And indeed, some of us may have been maybe not too serious when we're preparing for our dissertations, for the exams, but somehow this gathering has made me understand that there is a need for one to embark on a research that will add value to the health system in the country especially. This our country is a low socioeconomic one, so we look forward to those studies that can help better the life of Nigerians with minimal or very low costs. So I want to thank Shalina Healthcare for the privilege to have us come here, and the organizers, right from when it started, the organization, the WhatsApp group that they put us all in, and information was easily passed. I want to really appreciate you, Sir Ayo, and Ms. Ruth. They kept communicating with us and making sure we were good to go. I want to make a request again. I said it during my presentation. Please, Shalina Healthcare, look at hyoscine N-butyl bromide. Maybe call it Hyoshal, and make sure that it is very effective. Because indeed, that my study showed that we could help primary gravid women.
Please call Dr. Kiran.
Dr. Kiran.
Dr. Kiran, I hope you can hear that.
Please, it's important because this my study showed that primary gravid women in Nigeria could benefit from that cheap, easily available, and easily administered drug. Can be administered by any level of healthcare worker, primary, secondary, tertiary. Please work on it and give us your products. Let us see how we can use it and help poor women. Most of these women don't even go to the hospital to access delivery. Some of them come in emergencies. If we can look for a way to bring them in, letting them know that when you come with your first pregnancies, with this drug, you can have your delivery in the shortest possible time without fetal-maternal effect, we'll be happy. Thank you once again. Thank you so much. Okay, I've been asked to direct this my concern to Farm Emeka. Please, me and you can meet after this and we'll discuss, because my area, my region of study, my facility, we actually make use of it. It was part of my observation that made me want to put a scientific study to it. Our nurses use it at their discretion. There's not been any scientific basis to that drug. Yet, the women come, before cervical dystocia, they are doing cesarean section for a woman who would have benefited from a cheap drug. So please, the people involved, please try and see what you can do about that. Thank you so much.
Thank you. I want to assure you that you have spoken to the people that matter. And after this meeting, I'm persuaded Famimeka will call you aside to discuss with you. I'm persuaded. Right. Please, I don't know if there's any other contestant that will want to say. All right, Dr. Abdullahi. Thank you. See, Doc, that's Famimeka seated here.
Okay, good afternoon once again. I think I also want to congratulate and thank Shalina for this sort of program. Even though any of us don't emerge winner, I think it's a good avenue to share the findings of our works across centers. This will help in intersectoral and interinstitutional collaborations, and it will also guide junior ones or future researchers along the future course of our researches in the various fields we've presented. I think it's a very good initiative, and we thank Shalina for giving us this opportunity. And I think the organization of the program and our coming here was also very smooth and hitch-free. I think I'll also congratulate them on that. However, on the other side, this last part of the round two, I think it's good enough, rapid fire, I call it. Yeah, it's good enough, but I think to avoid bias, first, we need to have the same device across each individual, have the same internet connection, because I was asked to use my internet and messages and WhatsApp were just coming. I think I was locked out about 5 times during the course. So I think it would be better to get a tablet seasoned for the program and give it to each of the participants, but I still think it's good enough. Thank you. Finally, I just realized that among all your 12 categories of medications, there is no single ophthalmic medication. I don't know what we did to you. all the categories of your medications, none of them is an ophthalmic medication. I don't know if you have a fight with ophthalmology or what.
See, one thing I'm happy for, our MD is there, and she has taken notes. Right. ENT. Madam, this is MD, ENT, ophthalmic. We have been told we are not in that group. We are not playing in that category. MD is taking notes. And sorry, Dr. Abdullahi, what you said is germane. Giving equal opportunity, using the same device. I can assure you that we are looking at it. We are looking at it. Please, thank you very much. It's a positive feedback. We are looking at it as well. Thank you very much. Can I call on Dr. Ogide? Dr. Osegbe Ogali. Please, before you start devouring your lunch, please, we would like you to say a word or two to everyone. Thank you very much. I noticed that you already held the fork. I saw the angle of 36 degrees.
Good afternoon, everyone. First of all, I want to appreciate Shalina for putting this together. It's something that I really appreciate. Why do I say this? You look around TV channels and all that, you see programs that are really put up for youth. I don't want to mention names now, but you understand what I'm talking about. Programs that are not academic, programs that does not show any form of morals. But with this, I want to really give kudos to Shalina, and I want to also appeal to Shalina if there is a way this thing can be aired live. If there's a way it can be aired live. We have some things like, I don't want to also mention name for secondary school that they air live, mathematics competition and all that. So this is something that I want to appeal can actually be aired live. So once again, so let's put our hands together for that. So I want to also appreciate all the contestants. Like it's been said, we are all winners. And just to toe the line of my chairman, Society of Family Physicians, I've been part of this program from the beginning. And I want to really say that this particular edition has been the best so far. So let's put our hands together for Shalina. And I know and I believe it will always get better. So I want to go back to my meal now. Thank you very much.
Hold your phone. I'll call you again. All right, thank you. Please, let me also call on Dr. Oloyede F.A., Consultant Ops and Gyne, Oriliagege General Hospital, to also say one or two. Please, a round of applause for, please. Dr. Oloyede, please. Thank you. Thank you, sir.
Thank you very much. Good afternoon, everybody, once again. I really appreciate the pharmaceutical company, that is Shalina. When I was nominated by my medical director to come and represent him here, that's in person of Dr. Shola Piton, I don't know that what I'm really coming to here is more of academic. Well, because looking at the scenario, it is very, very educative. If we have this kind of opportunity too, when we are resident doctor, I think it will have helped a lot, because I know what I went through when I was presenting my dissertation in terms of statistics and some other things. So I want to say that Shalina, they should continue with the pace they are going. And I believe it will really help a lot. And at the same time, I think next year, you are still coming to Lagos to organize this same kind of grand finale, in which I may need to tell my medical director to give me the chance to come and witness it again, because it's very, very educative. Thank you very much.
Thank you very much, sir. Just to respond to one of the suggestions that Doc made the other time, maybe you should know this event is being transmitted live through PharmaStream. So we have some people online watching you live, even the way you are eating and handling your spoon. Sorry, I want to finish here. So
we've done that, but we can also still even improve on that. Maybe when we get more funds, maybe more sponsors, go on TV and the rest of them. But people actually watching as it is. Then all those feedback on the tabs and everything, well taken. Just same here. Last week we had similar one that we call Shalina Young Talents Award for final year pharmacy students. It was quite big, the little crowd here. So we noticed that as well, and we are going to take the needed corrective steps to ensuring that the platform becomes the same. What you've seen today is actually an improvement of last year. Trying to make everybody face, trying to go digital, not having to go to the VAR to know who punched first. We have improved actually, and we keep on improving. Thank you.
Okay, we're still waiting for the results being put together. While we wait, I'd like to call on Dr. Oyalo to give her remarks. Dr. Oyalo, a round of applause for her, please. She's the MD Market Doctors. Pet Doctors.
So good afternoon, everybody, and felicitations with Shalina for organizing this kind of event. And I'm happy to see the judges again this year. Welcome, sir. Welcome, Ma. And it was really nice having you. And like I say, it's always a learning point for those of us that don't want to do the academics. And this time around, like I was telling Mr. Foley, that the gender parity on this table, I don't like it. I mean, how can I have just 3 females, And you can see that the females did very well. Outstanding. 4. Where is the 4th? 1, 2. Okay. But even 4, can you imagine? I even missed 1. It's still, we need to look at that. Is it that someone said, is it that husbands are now not allowing wives to go to residency again, But all being said, I think everybody has tried, and this is a big improvement to last year. I mean, last year I think they were much fewer than this, and the prizes this year is much better. So congratulations to everyone. You're a winner, and looking to see you at the other end. Thank you very much.
Yeah, thank you. Okay. What she said about the gender parity brings to mind another one of my stories. And, quite an unfortunate one. A man went out with his wife. They went to basically catch some fun, and went on a donkey ride, because they had this ranch, right? So they went on a donkey ride. While they were on the ride, unfortunately, while standing with the donkey kicked. And when it kicked at the woman, she fell down, hit her head, and died. So it was quite tragic. Well, comes the day of the interment, lying in state, and the preacher on that day noticed something. He noticed that, of course, both men and women were going to the man to console him, and the women would go there and whisper something into his ear. And for all the women, the preacher noticed that the man always nodded in response to whatever they were saying to him. However, for the men, he noticed he kept shaking his head. And he noticed that consistently for all the people that went to him. And so after, he was curious because he was observing. So after the whole procession, he went to the man and he said to him, I noticed a trend while we're having the service of interment. I noticed that when the men came to you, you kept shaking your head. But when the women came, you were nodding your head. Say, what was it about that? And he said that, the women all came telling me how nice my wife was, how they know I would miss her, and all that. And he said, so I kept nodding, in response. However, for the men, they kept coming to ask me if that donkey was for rent. Okay, you get it when you get home. All right, we have a few more minutes before we announce. Femi. Okay, you are done. Please come. Your attention is needed. Okay, they're writing the big fat checks. We have some fat checks for the top 3 winners. 1 million naira for first place. A round of applause, please, for whoever the winner is in anticipation. 500,000 for second place, and 300,000 for third place. And in a few minutes, we'll get to know who these individuals are. You'll agree with me that they've all done justice. Of course, they won't be consultants today if they did not do justice to their dissertation. So we are glad to be here to celebrate with whoever the winners are. Actually, to celebrate with everybody that is here contesting, because like was said at the beginning, that you are all winners in your right. You came as champions from your various institutions to represent your institutions here. And of course, Shalina Healthcare is looking forward to something bigger and better come this time next year. And in a few minutes, we'll be coming to the final moments of this event. And every contestant. Remember that this contest held in the various institutions, they were not just handpicked, they are actual winners from their respective institutions. Yeah, and they were actually prize winners from their respective institutions. So this is simply the grand finale for what had happened in the various institutions that they represent. So I'd like to call on the MD, Madam Okpeyemi Akinyele, to do these honors. So she's going to be presenting to each and every participant this certificate of participation in this laudable contest. So in no particular order, please, if you hear your name, come forward for recognition. So I'm starting with Dr. Omolara Odunsi. Please, a round of applause for her. Paparazzi? Okay. Let me move this out of the way. Oh, okay, sorry, please. Dr. Odusi, please, let's use the background. Let's use the backdrop. Is it okay like this, cameraman? It's okay like this? Okay, they don't need to go up. Okay, then we have Dr. Anekan Linus Jackson. That's the doctor with the flu. Thanks for coming. Then we have Dr. Aikome Usialele. Usialele. Uswalele. Oswalele. Okay, I finally got it. Congratulations, sir. Then we have Dr. Oduola. Babatunde Oduola Owo. Dr. Kenechukwu Emefuna David. Dr. Saze Ude Ugwage. Dr. Lalere Oluwadare. Dr. Ikiroma Soke Pirim. Dr. Samuel Akpan. Dr. Numaku Sioma Josephine. Dr. Miriam Abdullahi. Dr. Kelaini Taiwo Suleiman. Dr. Ufadime Lawani. Dr. Nwafo, Ifeanyi Echezona. Okay. Dr. Maduka Collins Jidofo. Please, a round of applause for all of them once again.
Thanks, everyone, and thank you for your time and patience thus far, and for your participation. Before we move on to announcing the finalists, I have the pleasure of introducing to you all the representative of Shalina Healthcare Top Leadership, Arun Raj, the Chief Commercial Officer for West Africa. Please join me in welcoming him to the mic.
Thank you, Avi. Good evening, all. I stand on all the existing protocols. All right. It's a great pleasure to have you all here, and this is an activity which is ongoing for last few years. We have initiated this just to ensure that we are able to get the best minds together to bring out some of the best cases together so that we can take it back to the doctor fraternity and make them know that there are good talents in Nigeria, right? Even last time I was telling that I was reading the first surgery done on a fetus was by a Nigerian doctor, right? You know, it's a great achievement, right? So we sometimes think that people run away from this country because there is no medical facility over here. They want to do medical tourism and go to other countries and do it. Is it because there is no talents? Is it because there is no capability? The answer is no. We have good hands. We have capable people. We have knowledgeable people. If you go to US, if you go to UK, you go to any of those countries, you will see many professors, many teachers over there are from Nigeria, right? So it's not that there is no talent. There are talents. And not everybody need to do japa, right? So you see, we are just trying to see how we are able to ignite that thing inside you, right? You know, sometimes it is not just about practice alone. It's about how you are able to position yourself. Sometimes, you know, you walk into a project, there may be an international project coming in that says that we need medical doctors to take part in this. But you know, you may be not thinking in that way. You think that after my MBBS, after my PG, I have to just go into consultation. There may be something more than that. And it may require some additional skills that probably you're not looking at it today. So we are just trying to bring in aspects which could help you to bring that spark out of you. And you start seeing other opportunities. Medical doctors are not just required only for this. There are pharmaceutical industry which happens. There are research that happens. There are clinical trials that happens. Everywhere there is a need of medical doctors to be there, and there could be different set of skill set that you could bring forward so that you showcase yourself into that. So what we do is we try to get the young minds together, bring the best decision together, and then out of that, the best 15 is brought to Lagos. So if you are here, that means you are the best in the country today. Right? Now, at the end of the day, there are only few winners who will come out. I'm sure this could have been a discussion from last year that everybody who is here has to be rewarded. But I think we are still struggling to get a co-partner because, you know, doing an activity in Nigeria comes with a lot of expenses, a lot of money. Now, if you try to do that, and along with that, if you try to share the prize award with everybody, then the winner is not going to be excited about it. I hope you understand what I'm saying. So we are still trying to find out a good partner who also could contribute along with us so that we can make a reward for everybody. But today, I still apologize, we couldn't make that happen because of the economic situation. People did not come forward. They do not want to continue spend. Even for us, we were thinking, is this the right year? We have to still do this. We said, no, this is an investment. This is an activity we are doing towards the society we should continue to do irrespective of the situation in the country. So that's why we are here. So not everybody goes back with a reward, but be rest assured that you are the best in this country. That's why you are here, right? So I thank you once again, and it's great to have you all. And this is just a beginning for you all. There's a lot of those future opportunities. In Shalina, we are planning out to come with something new in Africa, which many other companies have not tried. So we as a company is not just in pharma space, we are there in consumer space, we are there in diagnostics, we are there in clinical research. We are also venturing into clinical research in Africa because many companies feel that in Africa you can't get a genuine data, you can't get a quality data. We are trying to change that thought process. We are initiating the clinical trials. We have already done a couple of clinical trials in Nigeria and in Ghana. We are trying to open up in a bigger way so that more companies could do clinical trial in Nigeria and the Africa part, right? Now, along with that, there will be a lot of opportunities coming up. We are coming with a new platform for doctors to communicate each other, to share clinical studies, to share best practices, to share a good case that you are able to successfully handle. Because, sometimes another consultant want to know how it has been handled and he's not able to reach out to the right person. They may be looking for a platform. So we are trying to create something where all the doctors could be able to communicate each other. So very soon we are going to come with it. You will hear from us in the month of April. And I'm sure with that we'll be able to make more progress from where we are today. Thank you so much. And congratulations to once again.
Thank you so much, Mr. Arun, the Chief Commercial Officer, Shalina, West Africa. All right, moving closer and closer to the high points of this event. Are we all ready? That yes is not stimulating. Are we ready? Great. Okay, Pamayo, please come up. Let's do this together. Earlier, she said something about, again, the fact that women here in this competition are less in number than the men. Actually, it's not an indication of how powerful the women are. It is not at all. We know that women are very powerful. Extremely powerful. Thank you. So there was this thing that happened in a little old church where when you go to church, they're always talking about the man being the head, and all that. And the fact that men ought to have control in their homes and should be in charge and tell the women what to do, tell the children what to do. And so it was now time for altar call, and the preacher says, all men should come forward. So all the men came forward in church. And then he said, all men that know that your wives control you at home, move towards my right. And virtually all the men moved towards their right, except this little short man that was on his left side. And the pastor was very impressed. I mean, here you had macho men with muscles, six packs and all that, moving to the right, saying their wives were controlling them. And there was this little man, if you saw his wife, massive, tall woman, and it was a little old fella. So he now asked him to share best practices. So he hands the mic over to him and he says, sir, can you please tell us how you are able to keep your home in order? Well, the man stammers for a little bit and he says, to be sincere, Pastor, she actually asked me to stand on that side. Women are that powerful. If you know, you know. Fama, are we ready? Okay. So, can you take a lead here?
All right, thank you very much. The hour has come. The hour of liberation. Hour of liberation has come.
Sorry, I think there's a comment from the panel.
Okay. So going straight, please, I would request the following to assist in presenting the gifts. For the third place winner, we will require the presence of, where did I put them? Those that would assist us for the third place. Right, Dr. Ogide Ozegbe, Dr. Ajibare Adeola, and Dr. Akimboade Francis. Please, we require your presence for the third place winner. We'll call on you when we get there. But for the three of you, please, you assist us to make the gift, please. I will call on you. Dr. Akimboade, please just have your seat. Dr. Akimboade, please. Thank you. For the second place, we require the presence of Dr. Oleyede and Dr. Sixtus Ozumba. We require your presence to help present the second place gift. And also for, okay. All right, for the first place winner, we will require the presence of Dr. Ademolu, representing the CMD of LASUT, Dr. Adebayo, Dr. Yalowo, along with our MD and CEO, Mr. Arun, and our MD, Mrs. Akinyele, for the first place winner. Right. So, without much ado, do I have the go-ahead from Foley? Right. For the third place winner, permit me to call on Dr. Ogide, Dr. Ajibare, and Dr. Akimboade. Please come forward, please, sirs. So for the third place winner for today, out of over 1,000 entries from the preliminaries,
okay, do we stay down here or do we go on stage? Okay, I think we should ascend the stage, the rostrum. Your drum rolls.
All right. For the third place winner, please join your hands. First, let me commend everyone. You have all tried. You are all winners. But please, as you all know, we must select the top three. So for the third place winner, please join your hands together as I call on the delectable, the beautiful doctor, all the way across the Niger, Dr. Miriam Abdullahi.
I'm tempted to call her the PHCN doctor.
She'll be going on with a cash prize of 300,000.
Congratulations, Dr. Miriam.
Sorry, Dr. Akimboade. A shift. You will agree with me that she did well. Just like everyone, she did well. Everyone did well, but based on perception of the panelists. Thank you, Doctor.
Round of applause for her once again.
Round of applause. Gently, Doctor.
Congratulations.
To help us present. To help us present the Second prize. Please let us welcome Dr. Loyede, Dr. As I said earlier, everyone has tried, but still, we must select the top 3. Please, with all modesty, permit me to call on the second place winner, National Grand Finale, Shalina Rising Star Award, Season 3. No other person than, any guesses? Any guesses? Please jam your hands as I call on Doctor. Light, I need more light. Doctor, I need more light. Your phone light. Professor. Dr. Onumaku Isioma Josephine.
Hey, only 4 women though. Yeah, I told you. Congratulations.
She's going on with a cash prize of 500,000.
Congratulations.
For the first place winner to present, please can I call on Dr. Ademolu, please, Dr. Adebayo, Dr. Oyelowo, Mr. Arun, and Mrs. Akinyele, our MD and CEO, CCO, to make the presentation. The race started sometimes in October, November last year. The race that are culminated in what we are doing today started around October, November last year. And today, so no need to show again. I'm sure we'll let this winner just come out. Let the winner just come out. And
no, did they see it? I don't think they saw it.
Incidentally, Prof, you helped me prepare a query for our CCO. After the... All right. We were delighted to tell you about... We asked the question, who is the one? Who does the cap fit? No one answered. No one had the guts to answer. No one dare answer. But someone has proven himself today, and he has ministered to us through his dissertation. He has ministered to us through the rapid fire. And some of us are convinced that she has done extremely well. She came all the way. I did a kilometer calculation, 878 kilometers to Lagos. 878 kilometers to Lagos. That's where she's from.
That should be somewhere from a middle belt or so.
Around there. So please, I will be announcing who the cap fits. Please, with a clap offering, join me as we welcome and appreciate a daughter of the soil, a son of the soil, this brilliant mind.
And woman.
No, it's a woman, she though. I don't say she. I'm sorry if I said he. So please join me, ladies and gentlemen. Let us celebrate the champion today. Doctor. 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 Doctor.
Doctor.
Doctor.
Doctor of doctors.
Doctor. Everybody say doctor.
Doctor.
Doctor, doctor.
Doctor, doctor.
Say it now.
Doctor, doctor.
Again.
Doctor, doctor.
Lead me to my destiny. I have waited patiently. I have vision, oh I believe. I know I can count on me. So stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up, stand up, stand up, stand up. Here we go, it's getting close. Now it's just who wants it most. It's just life, that's how it is. Cause we have our strengths and weaknesses. Oh, I have vision, oh, can't you see? I'm on the move, make way for me. So stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself up. Stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. 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 Stand up. Stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up, stand up, stand up, stand up. Here we go, it's getting close.
All contestants, please come on, please. All contestants, please come on. Finally, doctor, thank you.
Cause we have our
Thank you all,
strengths
doctor.
and weaknesses. Oh, I have vision, oh, can't you see? I'm on the move, make way for me. So stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself back up. And when I fall down, I have to pick myself back up.
Joy.
Don't sleep, wake up. Collect your money, collect your money. Rich, wake up. Collect your money, collect your money. Wake up. Tera, 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 go get the moolah. Wake up. Money to kala.
Vote of thanks. Mr. Arun. Vote of thanks for Mr. Arun.
Don't walk, you don't try.
Dr. Kiran.
You supposed to be
Dr. Kiran, vote of thanks from Dr. Kiran. Vote of thanks. Dr. Kiran, vote of thanks. The head of human generation.
So far, so good. Let me see you. Oh, lo, lo, lo. 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 Let me see you. Go get the dollar. Wake up.
Dr. Kiran. We want to see the contestants dance. To be led by Dr. Odusi. Dr. Odusi will lead the dance. Dr. Odusi, Malaria Odusi should lead the dance set. DJ, music, DJ.
Okay, thank you. So I think since everybody left, so I want to thank all the participants for coming. Thank you, Shalina, for organizing. And also all the faculties. Prof. Samela is busy. Thank you so much. Have a blessed day.
Thank you, sir.
trendybeats.com.
Modernization, chicken from one impression, street orientation. Modernization, from one impression. Feeling good, banana. Music don't need permission to enter a space. Anyway, anyhow, you know, say you go feel me. Music don't need permission to enter a space. Yeah, yeah. Anyway, anyhow, you know, say you go feel me.
More music on trendybeats.com.
money. My silence mode, but beast near me. Will it cause violence, but still peace near me. You don't have to hurt me before you win. You don't have to kill somebody before you sin. Oh, Charlie Browse, that they'll sub. Oh, they'll go far. Without God, someone wrote to Lua, so fucking Sherua. Even though I'm from you, love up the spoon, they'll judge. Tell him I get bad. That's how you lad. That's how you 1990, don't look big party. It makes me feel bad. More than to feel good. Now I'm feel better. Through the radio, Jellegba. To repay my one con. I said, put my one drug. Now I'm on top. Life more than any contour. My power in Nigeria. But the power in London. For one, keep on my life, boy, we want to Mommy, me, I see daddy me. I call up question me. Money bullet to revive, you share our demon. I want to senior me. One billion where you see money. I want to know you love. I'm for the copy me. First cash out to me, I'm on the if you rap Banzuka. Moko found a sharpshooter. And my brain about Dasita. Found fake nigga. I want to shame me, oh. Tell me why shameless. I'm staying white, me, but I stainless. I only got to leave me. On the realness. To read me silence, me know me saying a weakness. Shout out to JD, Arab, Aya. See why the Russia prime boy spending. It's my daddy, love me was splendid. Oh logo, Zomo, CIA, Bella. So, Mishama. Oh, you're right. You're right, Tony, but be sure you know. Over someone, no go in jungle.
More music on trendybeats.com.
It's so easy.
Ask about me. Until they mean, but won't me. I'm alone, but they do me. Seke bula. I'm still getting my moolah. Don't like Pelunera. You could talk by a teacher. Only power nigga. You don't follow you. And you don't follow you. Kí ló rí nílẹ̀, àwọn èèyàn ló máa rí nílẹ̀, má tẹ̀lé mọ́lẹ̀ owó, má tẹ̀jú ilẹ̀ mọ́lẹ̀, kó má bàdọ̀ balẹ̀, ìwọ ló máa fi kólẹ̀, fún wa sójà, mẹ́ta gbòòsà, àwílò ló kàn bá fún mi lọ́wọ́ mi pizza, késekése kásá blanca, òkun bá bí ṣàtà, step on the seat, mo pè ṣùdánù, mo kàn lẹ́sẹ̀ kan, ó tá mo rí déjì gan.